we have a trial. We are the part of this trial, and there are three groups in this trial. HS003 20 milligram per kg every 2 weeks by intravenous infusion along with tenofovir alafenamide. In the second group, we are giving 10 milligram per kg, and the third is a control group in which only tenofovir is being given. Patients have already received 6 months of therapy, and we are seeing good response to this drug. Then we had the small interfering RNAs. Small interfering RNAs are the double-stranded RNAs, and these RNAs combine with HBV RNA, not HBV DNA, HBV RNA, because they have the complementary nucleoside sequencing. So these RNAs prevent the formation of surface antigen. So this is a trial of 17 patients, 22 patients out of them 17 received the drug. But problem with this trial was that many of these patients developed flare. So the patients who were continued with the treatment, they showed good response with the HDV RNA level and surface antigen level, and they responded well to the treatment. So I have only 1 or 2 slides left. This is a new trial, and this is again a monoclonal antibody against binding site of the hepatitis B surface antigen. And then we have the small inhibitory RNAs, and there is a trial that is the phase 2 trial, and which shows good response to this combination treatment. And good thing is you have to give treatment only monthly. So this is a good drug, and so take-home points are that interferon pegylated is not a good drug. There is limited efficacy. However, we still give this drug to our patients because we do not have other choices. Oral nucleoside analogs do not improve the response to the pegylated interferon. We give pegylated interferon for 1 year, and sometimes we continue therapy for more than that if the patient is responding, but slow responder. We do not prescribe this drug in decompensated cirrhosis. Bulevirtide is if becomes available, but this is very expensive drug, so even this becomes available may not be affordable to our patients. And there are new drugs like lonafonib, lambda interferon, small interfering RNAs, and monoclonal antibodies that are in pipeline. Thank you.
Thank you, Professor Zegam, for such valuable information. It was supposed to be the last talk, but due to schedule problem, flight problem, a talk from the last session is adjusted in this session, which is HEV and pregnancy updates. It will be presented by Dr. Om Prakash, who is an assistant professor of gastroenterology at Aga Khan Hospital, Karachi. He is former General Secretary of Pakistan Society of Gastroenterology and has 50 research papers in national and international journals with 4 active research grants. Sir.
Good afternoon, ladies and gentlemen. Can you upload my presentation? यहाँ पे नहीं आ रही. ये नहीं है, पीछे पीछे लास्ट. इसमें मिक्स टॉपिक्स में पढ़ी है, मिक्स टॉपिक्स में पढ़ी है. मेरे पास कभी नहीं आती. So sorry for this minor technical errors. So yeah, and thank you the organizers who have invited me for this talk, and thank you for rescheduling the talk in a different session. It was supposed to be happening at 6 o'clock, but it has preponed. So the topic that has been given to me is very much relevant to our population. You know, this is a disease of our part of the world. As you will go through the literature and you come to know that this is a common disease. I'm sure that you must be seeing this in a very specialized population of our country. So disclosure none. So by the end of this talk, like we will be, so I will be touching upon the background, how the epidemiology, what is the clinical manifestations, underlying mechanism for the pregnancy-induced bad outcomes, and what are the treatment options available for the treatment of the pregnancy-associated HEV infections, and how do we prevent that. So HEV, as I'm sure that you might have attended the morning session by lecture by Dr. Maruf about hepatitis A, and she might have taught us about the what is the normal HEV and what are their presentations. So I will be just briefly going over through this again. So it's an hepatotopic virus that generally is usually self-limiting illness in majority of the adults. But as we are talking about the pregnancy, so it's a slightly different and specialized population. And so the background about, as per WHO, there's approximately 3.3 million symptomatic cases happen among the 20 million people who are infected in the world. WHO estimates that was about in 2015 that about 3.3% mortality is associated with the HEV, but in the pregnancy it's slightly different. And transmission is, as you know, that is orofecal transmission. Hepatitis E is found throughout the world, but it's predominantly in the Southeast Asia, and it is the like the subcontinent, the Indian, they diagnosed first time the hepatitis E virus in the Kashmir epidemic when it happens about 2-3 decades ago. So this is the virus structure, so I'm not going into the details into this thing for the sake of the time. So there are basically 4 genotypes, genotype 1 to 4, and the 1 and 2 are predominantly found in our region, and 3 and 4 are in the western region. And the 1 and 2 are the most pathogenic variant of the hepatitis E, which affects the, leads to the increased symptomatology and increased mortality, particularly in the pregnant women. And 3 usually happens in the older and western population, and they are not that much pathogenic. And if you see the disease spectrum difference between the younger population and the older population, so this younger population are more symptomatic, more severe disease as compared to the adult population. So this is again, broadly the hepatitis E virus is basically there, it has got like, how does it become virulent? So it's host factors and the pathogenic factors. So they are again the genetic makeup, so each individual differently behaves. So majority, as you know, the majority of the patients remain asymptomatic. It means their immunological response is very much strong against that virus. That's why they are not very much symptomatic in that case. And in some patients, you get that they can end up in getting the liver failure. So there's underlying genetic mutation, something is going on differently. That's why they lead to different things. And in some specialized population or immunocompromised or certain illnesses, they can lead even to the chronic hepatitis E infections as well. So the clinical manifestation, majority asymptomatic, but predominantly they have a typical hepatitis, which they are not different from the other viral or other causes of the other hepatitis diseases. So more or less the same symptoms, and the resolution is mostly like 4 to 6 weeks. It is the hepatitis which has got more cholestasis phase as compared to the rest of the hepatitis virus, and compared to non-pregnant, clinically do not differ from the pregnant women as well. So these are the common symptoms, and so this is, so hepatitis E is also associated with the extrahepatic manifestation as well, similarly like hepatitis A, similarly hepatitis B, and similarly hepatitis C as well. But hepatitis E has mostly, GBS is the most common extrahepatic manifestation that sometimes you find. Rest of these they can be like typically any viral infection can give you these atypical, and again it's underlying immunological response to these viruses that lead to extrahepatic manifestation. So the chronic hepatitis E, I told you that it can happen, and it is happen only in the specialized population. These are the immunocompromised or usually the hematological malignancies or HIV infections. So now back to the HIV, pregnancy and hepatitis E. So this is a very bad disease. Otherwise, it's a very mild disease. But if it happens in the pregnant population, it is going to be very severe disease. Like 25 to 25% of the patients have a mortality if they get this hepatitis E infection. There's a higher mortality in pregnant who progress to fulminant hepatitis failure. Like they can have a severe hepatitis, but they can progress to severe acute liver failure. They can have but if you check them, the serology positivity is very much high in suspected cases as compared to the clinical manifestation as well. So these are the pregnancy bad outcomes. That 38.5% of the patients, they can have a bad outcomes, which in terms of premature labor, gestational diabetes, latent jaundice, fetal distress, and maternal fetal transmissions. And what is the underlying mechanism is basically because of the certain hormonals which are increased in the pregnancy, such as estrogen and progesterone, that can lead to the increased severity of the hepatitis E in the pregnancy and latency in the pregnant woman. It has a high mortality, and a prospective study from Koro, I think he was the pioneer in developing or identifying the hepatitis E infection in the Kashmir part, Indian part of the Kashmir. And so they said that they found that the hepatitis E pregnant is about 15 to 20% of their patients. Among them, 25% of the patients will went into the liver failure. Again, then in non-pregnant, as compared to, they have a very large cohort of about 4,000 patients. Among them, they see that HEV was, non-pregnant women was only 2.1%. But in pregnant, it was about 17.3%. Similarly, these are all studies from the South Asia, like India, Pakistan, mostly these studies, and they are saying that the hepatitis E pregnancy prevalence, like it's not a community-based prevalence, it's not a community clinics, it is only in a specialized clinic from there. These are, I would say, case series. So it may not be a true reflective of hepatitis E in pregnancy, overall pregnancy, but there is series is showing that the prevalence is ranging from 30 to 50 or 60% of the hepatitis E in those patients. So again, it's showing that again the high HDI, like Human Development Index and low Human Development Index, again the outcomes is worse in the low development index, like ourselves, like India, Pakistan, or Bangladesh. So similarly, the high HDI countries have a lower bad outcomes. So the mortality as highest as go up to, even the people have reported up to the 56%, especially in the second and third trimester. There's another study which shows that this disease has a bad outcome in second and third, not in the first pregnancy. And there's another study that shows that why it isn't, like majority of the studies showing that the third trimester pregnancy outcomes are bad as compared to the first trimester. So local and regional epidemiology, this is a China experience. Again, they are showing that they are certain part of the Chinese provinces, they have a higher prevalence of the hepatitis C with the pregnancy. And their outcomes are also bad as compared to the like this region. So this is a study from KPK, which again shows that the HEV prevalence was again 15 to 20%, but their outcomes, if you see that the survival, like it is HEV positive, if you see that 14 deaths or 3% deaths, HEV negative again 3.4% deaths. Similarly, fetal outcomes again, it's about 90% to second and seventh, so bad outcomes in those as well. So, but first trimester, their outcomes are not bad as compared to second or third trimester. So again, this study from Pakistan again, it shows that 21 of 31%, like which makes about 15 to 20% of the patients, were positive in third trimester, 1 in first trimester. Overall prevalence was around 19%, 10 women were artificially induced, and 3 had premature labor, 4 delivered full term, and 3 died, and there was 1 intrauterine death. So these are the bad outcomes reported from our region as well. And HEV in clinical manifestation, the clinical manifestation is more or less the same, except that they have if they have developed the acute liver failure or fulminant hepatic failure, they can develop DIC, cerebral edema, and encephalopathy. And fetal outcomes, they can have a mortality, preterm delivery, low birth weight, or stillbirths. So these are the frequencies that you can find these 4 bad obstetric outcomes in these people. And why they have, because of the viral factors, hormonal factors, and immunity, which I alluded earlier, that these are the factors which leads to the bad outcomes in the specialized pregnant women. So again, it's a replication that we have a HEV1, which leads to this bad outcome in this population. So differential, again, because there are a variety of disease which happens in the second and third trimester of the pregnancy, as you know that. So we should keep in mind that it's not only HEV, there are certain other diseases that has to be kept in mind to differentiate between that, which are acute fatty liver of pregnancy, hyperemesis gravidum, intrahepatic cholestasis of pregnancy, severe eclampsia, HELLP syndrome, herpes, and Epstein atypical hepatitis virus as well that can lead to the hepatitis in the pregnancy. So that has to be kept in mind when we are giving these talks, encountering these patients. So second and third trimester are associated with higher mortality. Pregnant women are likely to progress to severe acute hepatitis in ALF, and breastfeeding is considered unlikely route of transmission. So breastfeeding is not contraindicated in these patients when post-treatment. So in the treatment, vast majority of the cases are self-resolution. In severe, like ACLF, rapid clearance of HA normalizing enzymes are noted with ribavirin treatment. Now mind that ribavirin is not indicated in the pregnancy as well. This is generalized treatment. Current treatment options for pregnant women with HEV1 or HEV2 related severe hepatitis or liver failure are much more limited. But the data is coming up with that the ribavirin is safe because, as you know, that the pregnancy causes bad disease in second and third trimester. By that time, the organogenesis is complete. So at that time, since ribavirin can be introduced in that, and there are studies available, I'm going to show you that. So these are the treatment options that you can think of hepatitis C, but not in the pregnancy. But ribavirin and sofosbuvir, they can be given in the pregnancy if you are suspecting the acute liver failure, particularly the second and third trimester, not in the first trimester. And there are experimental treatment are coming. So there is a very important concept of repurposing of the therapies. Ribavirin was not developed for the hepatitis E. Similarly, sofosbuvir was not developed for hepatitis C. So these indications have been repurposed and they are working in hepatitis C treatment as well. So that's why there's in the recent papers are published on sofosbuvir as well. So ribavirin and pregnancy. So what the data said, it has no teratogenicity in the second and third trimester. And because it is used in the third trimester, the organogenesis is complete. And again, it's suggested for the pregnant infected with HIV in the last trimester of the pregnancy. Therapeutic termination of the pregnancy. A majority of the people here think that if it's an acute liver failure, just think and terminate the pregnancy. No, it's not. You have to observe carefully, and it's not the only treatment for these types of patients. So again, these are the based on the data or experiment that has shows that the ribavirin, which is given in second and third trimester, it has not shown any kind of bad outcomes. However, it is given in first trimester, it has shown its teratogenicity. So one has to be very careful in giving the treatment in the second and third trimester. First time, absolutely contraindicated, but in second and third, find that if it is acute liver failure or acute severe hepatitis, then you consider this treatment as a safer treatment option. So again, it's a generalized treatment. Interferon, absolutely big no. Sofosbuvir, the data is coming up that you can consider for that, and their experimental treatments are also coming up. So then again about vaccine. So now the vaccine people are talking about hepatitis B. Again, the data is sketchy. It's in this region of the world. The research has been done. We were part of one of the study of hepatitis C vaccination as well. Long-term data is yet to come, but it is usually ORF2 related mechanism that they work. And these are the different trials that were conducted for HEV vaccine, and that has been now marketed as well. And so these are two vaccines available, and they have been used with limited indication because of the not 90% of the patients, they respond very well. So it has to be very carefully given. It has not been very well established in the Western world, and it's not the disease of them as well. So this is the efficacy of the vaccine, which shows that it is effective vaccination antibodies in the body up to 5 years. So the first time mass campaign of the vaccine was done in the COVID in the East African region. So then at that time they have seen that the data is still they are collecting the data for the long-term data, and they've given the vaccine on a mass level. So these are the indications of the hepatitis E vaccination, a very peculiar indications that, and the government has to adopt that thing. So I'm not going into the detail of these things, but it's there, vaccine is there, but its efficacy long-term is still plus minus. So it is unknown whether this is an vaccine, is safe for pregnant women and their fetuses, which are population especially at risk of fetal outcomes of particular genotype 1. Results obtained from pregnant women that had unintendedly been enrolled by mistakenly in the phase 3 study suggests that vaccine may be safer for them. It's maybe. However, because the study was not designed for this purpose, because this finding is not a definitive conclusion, a study that doesn't exclude pregnant women is currently running in Bangladesh, and there was some study in Nepal as well that those results have not yet come. So in immunocompromised vaccine, it is still unknown if the vaccine is protective in the high-risk group. And French study investigated reinfection HIV organ transplant recipient. They should, like these are the different vaccinations available. Okay. Finished? No, the conclusion slide is gone. Anyway, so viral hepatitis is the most common cause of jaundice in pregnancy. Viral hepatitis in pregnancy is associated with significant gestational and fetal complication. Adhering to screening guidelines is key to reduce mother-to-child transmission of viral hepatitis. Good hygienic practices are encouraged. Intern professional team, including the obstetricians, gastroenterologists, internists, intensivists, nurses, midwives, pediatricians are important in providing the holistic and integrated care to these specialized population of our patients. Yeah, thank you.
Thank you, Dr. Om Prakash, for updates. With this, our session is concluded. As we are running short of time, so we will not take any question at the moment. I will request Professor Altaf Alam for the final concluding remarks.
Thank you very much. A wonderful session. Kept me awake despite sleep catching up all the time. Thoroughly enjoyed all the talks. Zagam Abbas is the leading researcher in the world in hepatitis delta, and what a pleasure hearing from him. Om Prakash gave a very good account of hepatitis E. Certainly we are the people who can do a trial of Hicolin or hepatitis E vaccine in pregnancy, because both pregnant women and Hicolin are available in this country. So I encourage Om and his team to work on this. It has already been tested apart from the phase 3 trial where it was unintentionally given in Sudan, like you mentioned, by Doctors Without Borders, and they have given it to 3,000 pregnant women intentionally, not unintentionally, and so far the results are not out, but certainly there is nothing adverse as well. About ribavirin in hepatitis E, once I asked somebody and he said, who cares whether it works, whether it is a teratogenic agent or not? The fetus is dead, the mother is dying, who cares about the adverse events or teratogenicity of ribavirin in hepatitis E if it works? Certainly more applicable in chronic hepatitis E rather than in acute hepatitis E. I have never ever seen a single case of genotype 1 hepatitis E, acute hepatitis, where I found a positive RNA. So if RNA is negative, then probably ribavirin is not going to work and it is not worth trying because the results are not very good anyway. The other topics on PBC and autoimmune hepatitis were very well covered. Revised my topics without opening the books. What a great relief that I don't have to open the books. Junaid, you did a wonderful job. Batsab, very good as usual. Just to highlight that 2 drugs have been approved for PBC this year, elafibranor in March and saradelpar in August. So just last month. So 2 more drugs are there in our armamentarium, not for us, but certainly for the Western world, because the cost of, somebody asked me about the cost of bulevirtide because he wanted to get it from abroad, and I told him it is 50 million rupees for a 1-year treatment. And so, he never came back to me. So, you have to remember this, that the cost of these drugs, Ocaliva is 7.4 million obeticholic acid. So all these drugs cost a lot of money, and you have to keep this in mind, and you must know the cost, because one day a patient is going to walk up and ask you for a prescription, a bulevirtide, because he will get it from abroad. So you must know this. So overall, very exciting and satisfying session. Thank you all the speakers. Thank you the audience for being so patient and staying awake. Thank you very much.
Thank you, sir. With this, I announce the end of the session, and thank you all for being here. I know you people are tired, but there is just one talk, and very important talk, before the tea break, and hope you people keep sitting here. I invite Dr. Safia Sana for the next, to moderate next session. Just one talk, and a group photo of the presenters and chairs.
Assalamu alaikum and good evening, everyone. I am Dr. Safia Sana, working as a consultant gastroenterologist and hepatologist at Bulan Medical Complex Hospital, Quetta. I welcome you all on the 24th PSH conference. This conference provides a platform for us to present the gem of gastroenterology, where we get the chance to learn from our seniors, discuss the novel challenges, and exchange experiences and knowledge. Without any further delay, I will start our session by inviting our respectable chairpersons. I have the honor to introduce our first chairperson, Dr. Zayam Abbas, who has been an instrumental in shaping the future of gastroenterology. He is the head of the department and director liver transplantation program at Dr. Ziauddin University Hospital, Clifton, Karachi. Please, sir. With great pleasure, I introduce my second chairperson, Dr. Sher Rahman, who has demonstrated exceptional commitment to the field of gastroenterology. He is working as Associate Professor of Department of Gastroenterology at Khyber Girls Medical College, Peshawar. He is the Program Director, Postgraduate Training and member of Transplant Regulatory Authority at KPK. Please join me in welcoming our third chairperson, Dr. Mashood Ali, who has demonstrated exceptional leadership and commitment to the field of gastroenterology. He is the head of the department at Pakistan Institute of Medical Sciences, Islamabad. His contributions towards developing one of the most advanced therapeutic approach in endoscopy, including EUS at PIMS, and he has multiple publications in his honors. So now let's give a warm welcome to our speaker of this session, is Dr. Farooq Khan. He is Associate Professor in Transplant Hepatology and Advanced Endoscopy, King's College Hospital, UAE. Sir, please.
I'm really very sorry. I really am. Hannah, I know you all are waiting for tea, and I'm the last of the Mohicans before it. But the good news is only me in between you and the tea now, so I'll try to be quick. So you have to clap? Yes? And this will make the session quick, of course. So this is really a very, very boring talk. And I warn you now, palliative care, I'm really grateful to PSH that you at least have allowed 15 minutes for us to keep this alive. We talk about transplant, we talk about endobariatrics, we talk about viral hepatitis, we talk about everything. I have a serious disclaimer here. I have a problem with this Hippocratic oath, which actually forces doctors to save lives. I think the oath should be, my role is to look after patients, not to save lives. And there's a difference between the two. And I'll see if I can touch upon this. There'll be less data in this, so hopefully you wouldn't get a lot of bored. Palliative care is a job of an oncologist. है ना? Cancer वालों का काम है ना ये. Why hepatologist into this? What's the need? Why should we do it? It's the third most common cause, and it's killing young people. So this is where you and I come into this. People ask me, one way you do advanced endoscopy, you do all this, and how come you talk about palliative? And I think this is the physician in me. This is where it keeps us going to how we need to do for our patients, right? Regardless of east, west, south, north, whatever side of the world everyone is suffering. No healthcare system has now an ability to survive through this, right? Look at United States, look at UK. Every healthcare system is struggling, no matter what. Do we really need it? The answer is yes. Over 70% of the people with the liver disease, they are still dying in hospital. May I ask why? You knew it. We know the trajectory. Why are they still dying in the hospital? Acha chalo. There is a certain group of patients who, no matter what you do, the family is concerned, they're young people, they're dying, vomiting blood out of their mouths, and that's okay. But why the others are still dying in the hospital? Why families are still bringing them to emergency department? And some of them, far from the areas of Lahore, Karachi, big cities, are dying in the ambulances. Why is this happening? You and I knew this, we could have foreseen this all. But don't worry, this is the national statistics from NHS England, yeah? Even there, the 22% of the patients, knowing that they have deteriorating health and liver disease, are still dying in emergency departments. This is even worse, waiting for 6-7 hours before the doctor could see them. There was no need. आपको मुझे हम सबको पता था कि ये patients they're going down the trajectory. They're not a transplant candidates, they still continue to drink alcohol. Whatever the reasons are, why have we not planned it? More than 1 in 10 deaths of the people are from, and ये Pakistan के लिए important है. So the younger the patient is, the most the financial burden is going to be. We know this, why are we not doing well? And that's because there are several issues here. I think the most common is we have to raise our hands. We are the ones who are not able to understand the problem. There are barriers in our understanding as well as provision of care. I think you and I are the weakest link in the delivery of this. And unless we accept this, we are not going to deliver better. Yeah? And this is why I'm always grateful to PSH that they always allow me 15 minutes to keep on banging the drum again and again and again about this. Does palliative care help? So University of California did that very nice study really, and they said, अच्छा हम एक काम करते हैं, let's take the 157 patients, they come to hospital with decompensated liver disease. Some of them we just continue to do the acute care, and some of them we do the acute care, but we also give them a palliative care. So the palliative care team comes, they sit with them, advanced care planning, and make decisions very focused. And of the total cohort enrolled, only 10% were considered suitable for liver transplant. Who cares about ACLF? Grade 1, grade 2, grade 3. Only 10% who comes to your emergency departments are actually suitable for liver transplant. What about the 90%? They keep coming back and back and back. We knew it, why didn't we do it well? So therefore, the integration of these pathways are now important, right? What about Pakistan? So let me just very quickly share some strategic differences between Pakistan and the rest of the world. Let's compare us to the Italy and Korea, really. But if you look at age distribution, the green bar is Pakistan, right? This is a data taken from the Department of Health, yeah? And look how the younger population exists in Pakistan as compared to any others. So almost 70% are younger, the 40 years old. Look at the disease incidence, yeah? we outweigh every single nation which is really as extremely populated as we are in liver disease. So we can't walk away from this, right? When I was part of PKLI, this is the Punjab Health Survey, we found out that there are almost 2 million cirrhotics. It's just Punjab this is, right? 2 million. 20% will decompensate a year. No healthcare system can do liver transplant of 200,000 patients every day. You just can't do it. Take it or leave it. You just can't do it. So we do need to look after that. Achha, let's just move away from Pakistan. And this slide, we really work so Markov model is one of the models that generally nations and the public health departments do that. You talk about viral hepatitis in Pakistan, let me show you what's happened with the fatty liver disease in the western part of the world. So United States, total population is about 325 million, right? Okay, so just the fatty liver and the diabetes is about 18.2 million as we speak. That's the current population, right? If they do not change things, what they're doing now, in the next over 10 years, United States is going to need 65,000 liver transplants. They can't do it. Let's just face it, nobody can do it. So we use the same mock. So I completed a study recently in local Emirati population. I can't share the results because it's currently in the press. So we use that study, the outcomes from that local Emirati UAE population, and we plug it into the Markov model. And just Dubai being 3.5, 1/10 of the population of the United States really, we look at about 3.5 million population. So if we don't change anything in Dubai now, they're going to need 15,000 liver transplant. We are the first transplant program started in Dubai 6 months ago, and we've really just done about 12 liver transplants. Again, no health. So regardless of viral hepatitis, regardless of even the Western world, resourceful countries can't deal with this menace. Something has to change, right? End of life care. As soon as you use the word palliative care, the trainees, the relatives, nursing staff, they'll think I'm talking about end of life care, the patient is going to die. That's actually not true. And NHS England have defined it for you. End of life care is the care which is given to patients in the last 12 months of a life. I'm talking about palliative care. Palliative care is not end of life. And these definitions need to be born in our heads really. End of life has nothing to do with palliative care. Palliative care is where you know that patient is not going to get better. It might take 7 years for him to live. Why are we stopping the care, right? The other thing I think is young patients with the trajectory which is really difficult to understand, and that's where the problem begins. So in the blue bars, these are your healthy patients that are living a very normal life, and all of a sudden you get a cancer diagnosis and they die within 12 months. The green bar there is really is another cohort of yours, which is your elderly population, who always live at the low baseline. They keep getting better, 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 and keeps deteriorating. These are the ones all of us are very comfortable telling them, look, he's old, he's very frail, let's just talk about, don't do the CPR, blah, blah, blah. But look at the middle ones. These are your liver disease patients. So they're good function they start with. They have one hospital admission, they dip down. They then come back up. Then they have another, but may ask you all to look at the red line. Every time they come to hospital, the bar is going down. You're treating them, you're getting them better, they get discharged out of the hospital. But if you look at the bar, it still continues to goes down. And that's where we as a healthcare workers need to understand this. Deprivation, I don't have to stress too much. Pakistan is the one that we really, strategic government policies, we don't have funds. And then of course, the painkillers, we get scared. It's a social stigma, as just said, end of life care equals palliative care. Wrong, utterly wrong, that's not true. Understanding patient's journey as well, I don't have to convince you all. If your patient is a cirrhotic, if it's decompensated, we know no matter what stage of Charles he is, as long as it's decompensated, without liver transplant, the outcome is 3 to 5 years. That's a given mortality. There's no rocket science behind it. So therefore, once your patient is decompensated, palliative care starts at that point, end off. There really is what people should start thinking about. The very first episode of DECO, may that be encephalopathy, may that be a GI bleed, may that be anything at all, you either put them on the transplant waiting list and start palliative care. Why not? There's nothing wrong with it. So I think palliative care goes all across the board here, either the outpatients, inpatient, or even ICU care. Transplant and palliative care. So I'll tell you a very brief story here. The first time I mentioned this on my ward round, my registrar got upset with me that I actually talked about palliative care on a patient who's active on a transplant waiting list. Believe it or not. And he actually reported me that my consultant on the ward round talked about palliative care when the patient was active and the family is very upset. So the nursing matron had to take me to the corner and took me in the office, and I said, whoa, hang on. And that's the answer. 50% of the patients who are eligible for liver transplant, they actually die on the waiting list. 20% of the waiting list get delisted whilst they're waiting for it. ये important है. 50% patients जो आप transplant center को refer कर रहे हैं, they are actually not eligible for transplant. And somewhere we're going wrong here, right? वो patients जो transplant centers ने देख लिए हैं, and they are saying these are eligible for transplants, they actually go active on the waiting list. 20% get delisted within first 3 months of having them listed there. This is the real world data, this is. Higher MELD score, age more than 65, and of course the sarcopenia. They are the ones that increases. So now you actually know, whilst the patient's on the waiting list for the liver transplant, there are factors that you and I can pick up, and we can talk to those patients about palliative care. Frailty and sarcopenia, I think this is important, because frailty changes the outcome of your patient. How do I assess mortality? So top one is my outpatient. If I look at it, then inpatients, if you want to look at, so this is your transplant patients, is your MELD score, and ACLF is patients of mine who admit to the hospitals. So patient agar clinic mein aa raha hai, I assess and talk to them with the mortality on the Child-Pugh score, and I'll tell them your 12 months outcome is about 20% or 50% based on your Child-Pugh score. MELD score I use for my transplant patient, we all know that. I don't have to give you a lecture on this. Your inpatients is your ACLF. This is where I use ACLF, when you go and you assess them in emergency departments. Clinical frailty score is important because it's a state of vulnerability. And this is what you have to know. You're busy clinicians, I accept this. हम में से किसी के पास time नहीं है clinical frailty. But if your patient is coming with the son or the daughter holding their arms, supporting both sides, he is clinically frailty score 5. What does that mean? Look at the studies here. Major studies look at thousands of patients admitted to ICU. If the frailty score is 5 and over, the 20 and the 30-day mortality is over 60%. And these aren't the patients with liver disease. These are only your sarcopenic frail patients. Now put liver disease on top of that frail patient that comes to your clinic. Yeah? You already know that if he goes to ICU or HDU, the 30-day mortality before he walks into that HDU or ICU is actually 70% at 30 days. And this is important. And that's where we as a clinician need to tell the family. If they're pushing, that's okay. You say, I'm going to take him to ICU. We're going to do what we're going to do. But I want you all to understand that the outcome may not be as you think it is. And when the patient dies, there'll be less broken windows of the hospital. Maybe 2 or 3 less. But at least because you have used and you've told them that this is what it's going for. How do I assess mortality? Ben Hudson was one of our trainees at Nottingham. He's now a consultant, really. He's done a lot of work in palliative care. And he said, 5 independent risk factors. Agar ye 5 factors present aapke patient mein na, you can actually tell them that you're going down the trajectory, right? So child C, more than 2 hospitals in the last 6 months, or the admissions 1 year. If they continue to use alcohol, if they've been assessed at the liver transplant center, and they have said, no, you're really not eligible for transplant. And if the performance status is 3 or frailty score of 5, if that's what you want to look at. Presence of 3 or any more of these, of course, represents a poor prognostic marker. So we therefore want really integration of palliative care pathways into our system. You can take a picture of this. What I've done here, I've just put it all down for you. If any of these are present, you really, really do need to start your patients on palliative care discussions. You really do. Because any of this outcome is poor. Look for opportunities. I have 2 more slides, and then we'll all have nice coffee. Early discussion, really early discussion. And I'm hoping that I've given you enough substance now that which are the patients that you guys can accept that they're not doing too well, and you sit with their daughter, you sit with their family, and you tell them, I, as your doctor, will do everything in my limit, but my limit is way, way beyond the limit of nature. That I cannot change. So just bear with us, right? So look for it. Particularly जब वो पहली दफा discharge होता है ना ward से, that's the time. That really is the time that you just feed in. So next time when they come to hospital, they already know that this is another admission in the same degree. We do offer dedicated appointments to this family. अगर आपको पता लगे ये family थोड़ा सा time ले रही है, offer them a different appointment. Bring them back. And combined liver palliative care MDTs, this is also important. I put this slide for entrepreneurs and the trainees here. And this is where the paradigm shift is, right? So we have curative care, we have palliative care. Actually, don't make endoscopy units. Don't make acute hospitals. Don't buy ICU beds. If you really want to do it, invest in hospice. The nursing home concept, if you like. So these patients, all the busy hospitals, they can transfer it to you. And they'll say, you come as a day case, you drain their ascites. These patients will come to you, you look after their encephalopathy, put their hydration right. And really low cost. You don't need big oxygen plugs, you don't need radiations, covered walls, and what have you. So if you're really interested in business mind, this is where, and it's not me who's saying this is exactly what the Western world is now going for. Between the death and even the curative, for liver disease, you now have hospice sitting right in the middle, right? And I think this is one of the take-homes if you really want to take away from this lecture. Where do we go from here? Clearly identification, and I hope that I have now mentioned it to you. Communication to the family and education and team building. We have been lucky. We have ECHO, we have PSH, we have PKLI, we have the whole team here. And what we have started is every year, once a year, we run a palliative course. It's an on-site as well as online course. And what we're trying to do is to encourage trainees or consultant physicians who are outside from big cities. They run in the DHQs and they're running the busy hospitals and clinics. So they can come, and what we're also doing is once they've done that course, they go away, they still have a link with us, where they can get an advice. They have to be supported. If you're bringing a change, you have to be supported, and we're really, really quite happy to support you, you need. Thank you very much, everyone. Tea time now.
Thank you so much, Dr. Farooq, for such an informative talk. Before going for the tea break, I would like to ask my chairpersons for their concluding remarks.
Thank you, Farooq, for enlightening us about palliative care, which is very important topic. And this is the most neglected part in our practice, because these are the patients who need psychological support, they need social support, they need family support. We need to care their symptoms. We take care of the nutrition of these patients, which is after ignored and goes in a bad way, because of the taboos that are there. We have to clarify to the patient about these. And then this is like Farooq has mentioned about MDT and coordination of the care. That is very important. by some coordinator. We have to decide in these patients whether we have to provide them end of care sort of a support, and or whether we have to prepare them for liver transplant. So these are all things that are needed in these patients to go from palliation to the preparation for the liver transplant, and this is the MDT sort of approach that is required. So thank you very much.
Assalamu alaikum. Thank you organizers for inviting me for chairing this session. Thank you, Professor Farooq, for such a nice talk. And decompensated CLD patients are so many in our country, and most of them mostly we admit in the hospitals, and burden inside the wards increases. And these complications, many patients who are, mostly young age group people, some of them could be the bread earners for their families. So these patients, if we manage timely the complications, and if MDTs we conduct and the patients timely selected for transplant, many of them can be helped out. And we know we have sent many patients for transplants, and they are now effective for their families. They are working, they are earning for their families. Many of them we see around now, they are fully compensated and working for their families. So many of the decompensated patients can be, transplant can be arranged for them if they are well preserved, good candidates for transplant. And if the patient is, sarcopenic, frail, then and elderly patients, just so you can palliate them for, reducing their morbidity for the rest of how much life they have. Thank you very much.
Thank you, Dr. Farooq, for an excellent talk. In our setup, I see two changes over the years. One is, as you mentioned, there is a scarcity of beds and the patients have to compete for entry into the hospital because they frequently require admissions. And the other, I see the change in the trend. The gastroenterologists are now more focused in the biliary pathologies and the stones and the esophagus. And these patients will have to compete for getting admission in patients who are pancreatitis acute and chronic pancreatitis, biliary malignancies. So I see these two trends, the scarcity of beds and the change in the interest of gastroenterologists in the chronic liver disease patients as compared to the other GI pathologies. Thank you.
Thank you so much, sir. Dr. Masood Tareen will be our next moderator after the tea break. But before going for the tea break, I would like to invite my speaker and chairperson for the group photos.
Thank you so much. One announcement is here. General body meeting will be in next neighboring hall after last session of today's. General body meeting after last session of this day. Thank you.
There will be a break of only 15 minutes. Please come after 15 minutes.
Bismillahirrahmanirrahim. Good evening, everyone. I am Dr. Masood Ahmad, currently working as consultant gastroenterologist and hepatologist at Koita. I am truly honored to be moderating the important session today. We have distinguished a lineup of chairperson and speakers who will be sharing their knowledge with us. And I would like to start by introducing our respected chairpersons. So firstly, I would like to introduce Professor Johar Amin. He is a well-known authority in hepatology. May I please welcome Professor Johar Amin. My second chairperson for today's session is Dr. Saqib Ahmed. He is consultant gastroenterologist, FRCP. He is trained in advanced endoscopy at Nottingham University, and currently he is serving at Sherwood Forest NHS Trust. My third chairperson for today's session is Dr. Adnan Salim. He is another expert in his field with numerous publications. And may I please welcome our fourth and final chairperson, Professor Dr. Abdul Aziz Sahito. He is the head of Department of Medicine at People's University of Medical and Health Sciences. He is having 2 years of post-fellowship training in gastroenterology, and he has developed the GI department at his university. Now let's begin with our today's topics. My first topic is risk of bleeding due to invasive procedures in cirrhosis, how to evaluate and optimize. This topic would be presented by Professor Dr. Sher Rahman. He is Associate Professor of Gastroenterology at Khyber Girls Medical College, Peshawar, and Program Director for Postgraduate Training. He is a member of Transplant Regulatory Authority. May I please welcome Professor Sher Rahman. Sir, please.
Bismillahirrahmanirrahim. Assalamu alaikum. I thank Professor Ali Haider and Dr. Dawood Ghilzi for inviting me. I will be talking about the risk of bleeding due to invasive procedure in cirrhosis, how to evaluate and optimize. I will cover the historical context of hepatic coagulopathy and the risk of bleeding associated with different invasive procedures that we plan in cirrhotic patients, and the different coagulation and hemostatic parameters that are available to assess this risk, and the different strategies that we can adopt to prevent and treat bleeding. To give you an idea of the challenges that we face in our everyday clinical practice when we encounter planning procedures in cirrhotic patients. Case one is that you are conducting morning round and ask your resident for 5-liter acetic fluid paracentesis in an HCV-related cirrhotic patient who was not responding to maximum doses of diuretics and salt restriction. However, the resident pointed out that patient's INR is 2.5 and platelets are 80,000. Now, 4 options. You instruct to go ahead with paracentesis, correct INR with vitamin K and then do paracentesis, correct INR with FFP and then do paracentesis, correct INR with FFP and transfuse platelets and then do paracentesis. I will project these cases at the end of my presentation. Now, case 2 is your senior registrar is doing colonoscopy in an HBV-related cirrhotic liver patient who has presented with lower GI bleeding and dropping his hemoglobin to 9 gram deciliter from 11 gram. EGD is normal. He is on injection vitamin K as his INR is 2 and his platelets are 90,000. He finds an 11 millimeter single friable pedunculated polyp with some ooze. The rest of the colon is normal up to terminal ileum. He seeks your opinion. You instruct to go ahead with polypectomy. Wait for 3 days for INR to get corrected and then do polypectomy. Correct INR with FFP and then do polypectomy. Correct INR with FFP, transfuse platelets and then do polypectomy. Case 3. You have admitted a patient with cholangitis and obstructive jaundice secondary to CBD stones. MRCP has reported 12 millimeter CBD with 3 stones, largest one 9 millimeter. However, he has turned out to be a CV-related cirrhosis. His INR after 3 days of injection vitamin K is 1.9 from 2.5. His platelets are 75,000. His leukocytes initially improved with antibiotics but have become static at 14,000 and he is still getting spikes. Now we have 4 options: transfuse platelets and FFPs and then do ERCP plus sphincterotomy. Go ahead with ERCP plus sphincterotomy. Continue with antibiotics and defer ERCP. Refer to IR for PTBD. Historically, cirrhosis liver has somehow been associated with bleeding, and the main culprit for giving us, or the factor for giving us this impression and strengthening these impressions are two. One is variceal bleed and the other is the INR. Variceal bleed is the major complications in patients with cirrhosis, and this is one of the commonest emergency that we see in our GI patients ward. If we look into the mechanism of variceal bleed, it is basically the increase in the pressure in the portal mesenteric venous system, and because of that the patients bleed. And this bleed has nothing to do with any derangement in the hemostatic system that happens in cirrhosis, but it gives us an impression that cirrhosis is associated with bleeding. The second is the deranged INR that we see in patients with cirrhosis. The INR basically based on prothrombin time, and it measures the activity of factor 1, 2, 5, 7, 9, which are the prothrombotic factors. And their levels is decreased in cirrhosis patient because of liver dysfunction. But the INR is telling us only part of the story. If we concentrate on the right side of the figure, there are some other changes that also happen in cirrhosis. Like the von Willebrand factor level is increased, which counterbalances the decrease in platelet counts. And at the same time, because of the venodilatation, the endothelial secretion of factor 8 level increases, which counterbalances the decrease in the prothrombotic factors on the left side. And at the same time, there is acquired deficiency of the anticoagulant factor of protein C along with S and antithrombin and plasminogen. So on one hand, the INR is only telling story of the changes that happen on the left side, and it gives no information of the prothrombotic changes that happen on the right side. So in cirrhotic, in the hemostasis, there is not only decrease in the prothrombotic factors, but at the same time, the antithrombotic factors are also influenced. So there is a rebalancing of the hemostasis. And in compensated cirrhosis, it is suggested and it is said that the data shows that it is tipped towards the prothrombotic state. So one is this rebalancing of hemostasis and the inability of the INR, although it is prolonged and it is deranged, but it gives only part of the story, and it gives an erroneous impression that the cirrhotic patients are towards the bleeding side. Now, but there are two problems with this rebalanced hemostasis. One is this balance is very precarious, and it is grossly influenced by the ongoing liver dysfunction or the presence of infection or the presence of impaired renal function. The second problem or challenge is that at the moment we don't have effective parameters or lab tests that can give us an exact idea that to which side this balance is shifted. That at any time, whether if we want to assess and we are planning a procedure which carries a risk of bleeding. So we would like to have that this hemostatic balance, whether it is shifted towards the prothrombotic side or it is shifted towards the bleeding side. So at the moment we don't have such an effective tools. We, in everyday practice in cirrhotic patients, we plan a lot of procedures. And the risk of whether they have a high risk of bleeding or a risk of bleeding is based on the reported rate of bleeding in literature. Like if the rate of bleeding is more than 1.5%, they are categorized as high risk procedures. I've taken this table from ASLD guidelines, and on the left side, the low risk procedures show the common procedures that we do, like the paracentesis, thoracentesis, the venous line access procedures, and the diagnostic upper lower GI endoscopy with mucosal biopsies, ERCP with stent placements and diagnostic US, along with dental cleansing and non-extraction procedures. And on the right side, the high-risk procedures include the polypectomies, the ERCP plus sphincterotomy, the EUS with FNA, FNB. According to this table, the ASLD have put the band ligation in the low risk category and the transjugular liver biopsy in the higher risk category. But the recent EASL guidelines they have published in 2022, they have put the band ligation in cirrhotic patients as a high risk procedure and the transjugular biopsy in the low risk category. Now let's review the available coagulation and hemostatic parameters in cirrhotic patients, that what information they give and whether they are helpful in predicting the bleeding that would happen with this procedure. INR, as I mentioned, is based on the PT, which measures the activity of factor 1, 2, 5, 7, and 10. And the INR gives us information about only part of the derangement in the hemostasis system. So if it is deranged, we should not, it doesn't mean that the whole of the hemostatic system is tilted towards the bleeding side. So we should not base our decision on a deranged INR in a patient with cirrhosis. And of course, it is not a good measure of bleeding risk. And similarly, FFP should not be given to correct INR in a patient of cirrhosis who presented with variceal bleed, because this is counterproductive. The volume of the FFP increases the pressure in the mesenteric system portal and further aggravates the variceal bleed. Platelets, we observe that they are low in cirrhotic for various explanations. But at the same time, we know that there is increase in the level of von Willebrand factor that balances the reduction in platelets. So is there any safe platelet level? The AGA, ACG, and EASL agree on a cutoff level of 50,000. Any level above 50,000, the high-risk procedures can be carried out safely, and the bleeding risk is as in the non-cirrhotic patients. And if the level is less than 50, then it is suggested that they should be corrected. And the Society for Interventional Radiology suggests 30,000 as a cutoff mark above which the high-risk procedure can be carried out. Fibrinogen has been found to be low in cirrhotic patients. At the level less than 100 milligram is associated with spontaneous bleeding and procedure-related bleeding. But then there is a caveat that it is low because of the critical illness and patients who are critically ill as well. So at the moment, it is the evidence is not robust to the extent, and it is not recommended that if a cirrhotic patient is found to have a lower level less than 100 milligram, so a prophylactic transfusion or a correction should be done. It is not recommended. However, if a bleeding happens with an invasive procedure in a cirrhotic patient where the pre-procedure level was less than 100 milligram, so it is suggested that it should be optimized to a level of 100 to 120 milligram that helps in arresting that bleeding. There were 4 randomized control trials in cirrhotic patients where the viscoelastic tests were assessed for the requirement of blood transfusions in both variceal and non-variceal bleed. And it was found that they were effective in reducing the need for blood transfusion. But those trials were not designed to check whether the viscoelastic test will be helpful in predicting the bleeding or not. And a recent study where more than 300 patients underwent liver biopsy, and where viscoelastic tests along with the other tests like thrombin generation assay were assessed whether they can predict liver bleeding, liver biopsy related bleeding or not. And it was found that they couldn't predict the liver related bleeding, by liver biopsy related bleeding in those patients. So up till now regarding the viscoelastic test, the data is scarce, and at the moment we neither can't recommend for doing these tests before invasive procedure and nor against the viscoelastic tests. So what could be the strategies when we are planning an invasive procedure in patients with cirrhosis? We should take a detailed history that includes antiplatelets medication and anticoagulants, and these are dealt as a non-cirrhotic. Along with, we should screen whether the patient has any infection and any renal impairment or not. So before going off the further procedure, these infection and AKI should be addressed. Then we should establish that the procedure that we are going, what is its risk of bleeding? And then we should check the baseline hemostatic parameters like the platelets, fibrinogen, and INR. And before doing a high-risk procedure, if the platelet counts are more than 50,000, should we transfuse platelets? Most of the professional societies agree that if the platelet level are more than 50,000, they should not be prophylactically corrected. And if the platelets counts are less than 50,000, most of them agree that these should be corrected with some qualification by the EASL and the BSG. And for PTINR, again, there are uniform agreement that this should not be corrected and FFP should not be given to correct this INR. For fibrinogen, there are no specific recommendations for prophylactic correction. And regarding the viscoelastics text that this data is scarce and there are no recommendation either in favor or against doing these tests when planned an invasive procedure in patients with cirrhosis. So in view of what I have told, there is a suggested algorithm that whenever we plan an elective procedure in patients with cirrhosis, we should look for antiplatelet or anticoagulant medication that the patient is taking and check for any infection and renal failure, and these should be optimized. If these are not the situation, then we should do two things in every patient. One, to assess the risk of procedure and measure the platelet count. Like if the risk of procedure is low, so regardless of the patient platelet level, we can go ahead with the procedure. On the other hand, if the risk of procedure is high, and we check the platelet counts, and if they are more than 50,000, we can go ahead safely with the procedure. On the other hand, if the platelet counts is less than 50,000, there is a general agreement that they should be corrected. However, EASL has given some qualification that if the level is between 20 to 50,000 and local mechanical therapy are not effective in case the bleeding happens, that they may be corrected, and if it is less than 20,000, then they should be corrected. In case we take all these precautions and still the patient bleeds, then what we can do? The first step is to employ mechanical therapy that consists of local compression in any form, like local pressure or the application of clips. And if these are ineffective, then vascular embolization or even surgical repair might be employed. And correction of any coagulation abnormalities that were present before going for the procedure. While doing all, the portal hypertension component should be taken into account. If the platelets were low before the procedure, they should be corrected with platelet transfusion. And similarly, if the fibrinogen concentration was less than 100, in case of bleeding, they should be optimized to 100 to 120 milligram. And the FFP and the prothrombin complex should only be infused when there is hemorrhagic shock. And tranexamic acid can be given in the case of hyperfibrinolysis, but caution should be taken if the patient has already portal vein thrombosis, then these patients are at risk of developing venous thrombosis. While there is no role of desmopressin and factor 7 in the management of these patients. So coming back to my case 1, I would suggest the approach to check the level of the risk of procedure and the level of platelets. For case 1, the risk of procedure is low and the platelets counts are more than 50,000, so go ahead with paracentesis. For case 2 again, the risk of procedure is high, but the platelets are more than 90,000, so go ahead with polypectomy. And case 3, the platelets are more than 75,000 and the risk of procedure is high, but go for ERCP plus sphincterotomy. Thank you. The take-home message is, before I say, thank you, INR is good at giving information about liver dysfunction, but it is poor about hemostatic status and thus should not be corrected. The risk of procedure and platelet counts are mandatory before planning any procedure in patients with cirrhosis. Fibrinogen prophylaxis has no role. However, its level is kept above 100 to 120 milligram with fibrinogen concentrates infusion in acute bleeding. FFP is only recommended in hemorrhagic shock. Acute bleed procedure related is managed with mechanical therapy consisting of local compression, vascular embolization, or even surgical repair along with hemostatic optimization as required. Thank you.
Thank you, Professor Sher Rahman, for that enlightening presentation. If anybody is having any question, he is feel free. Second, uske baad. Okay. My second topic for today's session is approach to drug-induced liver injury, and it would be presented by Dr. Gibran Ayub. He is Assistant Professor of Gastroenterology and Director Research at MMC General Hospital, Peshawar. Dr. Ayub is trained in Yorkshire, UK, and has more than 70 national and international publications. And his special area of interest include bowel disease such as IBS, IBD, fatty liver, and he is having advanced endoscopic procedures like ERCP. So I would like to please welcome Dr. Gibran Ayub for second talk of today.
Thank you very much for a very nice introduction. I would like to thank Professor Ali Haider, Professor Rasad Chaudhary, and Dr. Dawood Khilzai for their kind invitation. While doing this talk, I thought about it that it is one of the difficult hepatology practice as far as diagnosis is concerned. So I place this picture, which we remember from our early childhood, and it is one of the favorite games of the children, and it's a musical chair game. And in the end, you have got one winner, and it keeps on rotating. So we'll come to it in a bit. So I'd like to start with the case scenario. A 20-year-old man with no past medical history presents to ER with fatigue, abdominal pain, nausea, and jaundice. The only clue he gives you is that he had a weight loss supplement 2 months ago, and these are the liver function tests. You see the AST above 1,000, the ALT is above 500 as well. The total bilirubin is quite high, and INR is 1.35. You have done a whole range of investigation, and that has shown that everything is normal, including the autoimmune screen, ceruloplasmin, and even the imaging, which has not shown any evidence of biliary obstruction. So, the drug-induced liver injury should be considered as any acute liver injury, provided there is no evidence of biliary obstruction. The liver biopsy and the HLA testing can certainly help in differentiating the drug-induced liver injury, but it will not help in the diagnosis. So it will differentiate the autoimmune hepatitis from the drug-induced liver injury, and there is no high-quality evidence that the steroids can be used to treat DILI unless or until there is coexistent autoimmune hepatitis. So DILI usually occurs after a latent period from few days to several months, while on the other hand, the drug overdose can occur from few hours to days probably. And up till now, especially in the West, the prevalence is quite high. Nonetheless, the augmentin is at the top of the list. And if I go at the further slide, it is one of the most commonest emergency admission in the UK. According to a data of 881 patients, it accounted for 15% of cases, especially the idiosyncratic one, because there are two classes mainly. One is the direct and second idiosyncratic. And it can progress to acute liver failure, accounting to 7 to 15% of cases. And this is a very good table which shows that you have got the therapeutic classes in which the antimicrobials one is at the top of the list. The augmentin, which is being used for commonly by us, is at the top of the list, and it is 408 Then we have got herbal medication, then we have got cardiovascular agents, and it goes to the top, from the top to the bottom, considering of rheumatology and GI agents as well. The pattern of the drug-induced liver injury are very, very important to be recognized. And the basic formula is to have an R value that is calculated by the ratio of ALT upper limit of normal and alkaline phosphatase. So in cases of hepatocellular, it is more than 5. In cases of cholestatic, it is less than 2, and the agents are being shown very clearly. And if it is a mixed pattern, it is somewhere greater than 2 and lesser than 5. So it is very, very important that you need to have these things in mind. The severity is very important as well, but most importantly, the degree of the elevation of liver enzyme, it does not accurately predict the severity of injury, because it cannot give you any impact about the outcome. But this is important, that the outcome is worse when acute liver failure develops in drug-induced liver injury, especially in paracetamol overdose, because you have got encephalopathy, you have got a deranged INR, and that patient should be urgently referred to liver transplant center. Again, why I have placed a chessboard over here. You cannot give up on a patient with drug-induced liver injury, because you will think, you will reevaluate the patient, and the king and the queen will rotate all the time. So it is very, very important. And the first thing which you need to ask the patient is to take a basic good history, do a basic good clinical examination, because they form the cornerstone of the diagnosis. So ask about the history of herbal medication, ask about the history of any drug the patient has been using, and determine the onset of the liver injury after the exposure, which is the latency, the course of the reaction after withholding the medication, which is the D challenge, and the recurrence of the re-exposure, the time to resolution. They are all crucial to a diagnosis and also to establish a temporal relationship with the suspected agent. So basically, it's a diagnosis of exclusion. You need to do a full virology screen. You need to do an autoimmune screen. So starting from hepatitis A to E serology, autoimmune screen for autoimmune hepatitis, very beautifully described by Professor Arshad Kamal Bhatt. You need to do even an MRCP to rule out biliary obstruction, because by definition, you need to rule out biliary obstruction. Ischemic hepatitis, history of alcoholic, history of non-alcoholic fatty liver disease, and ultrasound will be very, very helpful. If fibroscan is not available, that will help you in grading the fatty liver as well. So this is actually the crux of my talk. So whenever there is an acute liver injury or worsening of chronic liver disease, or there is an acute jaundice without an evidence of biliary obstruction, you need to ask about the history of recent exposure to antibiotics or over-the-counter medication in the last 3 months. You suspect daily, you withhold the drug while waiting the workup. So you do all the tests which I have just mentioned, including the autoimmune screen and the imaging. So if no alternative cause is found and there is an improvement in the liver function with the temporal relationship with the suspected drug, you need to diagnose daily, stop the drug, and the patient will improve. On the other hand, if there is no improvement and there is clinically worsening, you need to refer the patient to a specialist center. On the other hand, if there is alternate etiology that is being confirmed, you treat accordingly. Many people ask this, what is the role of liver biopsy? The role of liver biopsy can help in differentiating it from autoimmune hepatitis. It is not mandatory to be done. Again, I ask history, go through your clinical notes, go through the clinical examination. That is very, very important. In fact, it is not mandatory because it has got no specific histological pattern. The histological pattern can vary. Like, if you see in this picture, there may be prominent portal interface inflammation. There may be neutrophilic neutrophilic infiltration, plasma cell and lymphocytes. There may be lobular inflammation and ballooning, but you see such picture in autoimmune hepatitis as well. So it's not mandatory to be done, but it can help in differentiating the patient of autoimmune hepatitis from drug-induced liver injury. So liver biopsy is justified when autoimmune hepatitis is one of the top differential diagnoses. There is an incomplete or no biochemical resolution after discontinuation of drug. There are atypical laboratory findings, and liver injury is related to checkpoint inhibitors. The role of pharmacogenetic testing is important. As a diagnostic test in patients with DILI are compared to those of autoantibodies, and immunoglobulin profiles are routinely performed in clinical practice of acute liver injury. There are different agents, so HLA-DRB1, DRB1401, HLA-B5701, and they have been written in the British Society of Gastroenterology guidelines that they can help. But again, I would say history is important. Discontinue the drug. If the patient improves in the terms of the liver function, that is important. So, sometime the patient can give you a direct history, sometimes the patient will give you an indirect history. Like she sometimes tells her mother that make him to arrange a dinner for us in Monal. On the other hand, they can directly tell you that we have taken herbal medication. So patient needs to be digged out, and patient need to be revisited and re-evaluated at multiple times. Briefly, if I tell you what is the basic differences between the direct and idiosyncratic, so intrinsically, direct one is hepatotoxic, it is dose related, it is predictable. On the other hand, the idiosyncratic one is not dose related, it is not predictable, and it has got a variable onset lasting from days to several years. On the other hand, the patient with the direct one can have rapid onset of few days only. The most important step is that you have to withdraw that drug. That is most important. Empirical treatment with corticosteroids is not recommended unless or until there is an autoimmune feature, and that cannot be confidently differentiated from autoimmune hepatitis. However, there is an emerging evidence that liver injury and subgroup of these patients resolves without immunosuppression. In the event that the steroids are initiated, the distinction between the DLI and autoimmune hepatitis is not unclear. That is the point that you are justified in your treatment that the steroid should be given. The stoppage of the medication is one thing, but re-challenge of medication educated as a causative agent with 30% of cases developing DLI associated with jaundice. Hospitalization is associated with 52% in such cases. So you have to be very, very careful about such patients. So in direct, you have to stop the suspected drug, N-acetylcysteine for acetaminophen liver injury. Transplant is warranted if there is a high NR or alternate changes. Option with limited data is for it's ursodeoxycholic acid for cholestasis and corticosteroid for autoimmune hepatitis. In idiosyncratic one, you have to rule out other causes, discontinue the culprit medication, and transfer or refer for liver transplantation. This I've already discussed. There are no randomized control trial about the use of corticosteroids. So if you remember that patient, the first scenario, in this case, the ANA is positive. What do you think the case is? Any postgraduates? And IgG is quite raised. Obviously, it is autoimmune hepatitis DILI's clinical syndrome. In this case, steroids are helpful. What if the patient has got hepatocellular carcinoma and patient is receiving PD-1 inhibitor therapy with nivolumab? Simple hepatitis in patients with hepatocellular carcinoma, ALT and AST ratio 3 to 5 levels, upper limit of normal, total bilirubin is 1.5, 3 times the upper limit of normal. You can hold the nivolumab. You can permanently discontinue it if they are 5 times the upper limit of normal. In hepatitis with hepatocellular carcinoma, the indications are quite different. You can see it for yourself. So in the end, my time was being cut short, but I understand time is of essence. The solution to failure in reaching a clinical diagnosis is almost always revisiting the history and performing a detailed clinical examination. That is very, very important, and drug-induced liver injury is not an exception. If you don't take a proper history in clinical examination, आखिर में ये हाल होगा. Thank you very much.
Thank you so much, Dr. Ayub, for your comprehensive talk. Now let's move to our next topic of today's session. Our next topic is treating kidney injury in cirrhotics, and it would be presented by Professor Nasir Hassan Lak. Let me introduce him. He is head of GI department at SIUT Hospital, Karachi. He has numerous publications with over more than 200 publications nationally and internationally, and he is also a decorated champion of endoscopy. So he will discuss the complex challenges of managing kidney injury in cirrhotics. Sir, please.
Thank you very much. Actually, this is a bone of contention for a hepatologist to really go about these patients, especially when they are admitted. So I'll again start with the history to stimulate you that a 54-year-old lady, she's already been seen by you previously many times. She has decompensated cirrhosis, presented with abdominal pain, distension, and decreased urinary output for the last 2 days. Ultrasound abdomen is normal except for being liver cirrhotic. The cauteromedullary differentiation of the kidney is normal. Lab reveals there is a possibility of SBP, and serum creatinine is 1.5. We'll come back to this case at the end of my talk. Then we know that these patients are predisposed to have chronic problems, and they are predisposed to develop renal dysfunctions. And it is associated with the immediate and long-term outcome as well. And 30 to 35% of patients of cirrhosis will have some type of kidney injury, and mostly it is acute kidney injury. So the other terms used are acute kidney disease and chronic kidney disease. The nomenclature has been changing over the past few guidelines, but now it's a major paradigm shift. Why I'm saying so? Because acute kidney injury has to be understood by the hepatologist, because there is no nephrologist standing behind your shoulder to help you in this very condition. This patient is your patient and you have to own it, whether you like it or not. There is some intricacy in seeing things from a hepatology perspective. Why I'm saying so? I'm just alluding this point that increase in serum creatinine of more than 0.3 milligram per deciliter is a minute change. Working with the nephrologist for the last 2 decades, what I have imbibed is a doubling of baseline creatinine decreases 50% of the GFR. It's a very significant information. So here they have, for this very recent change in their nomenclature, what they have said is like there is no structural problem in this kidney and it can progress to HRS-AKI, which was previously known as HRS type 1. If I further go about the definitions, you will see that AKD is something in which the GFR has significantly deteriorated less than 60 ml per minute for less than 3 months. So these definitions are so dogmatic that sometimes you feel that you are being chained. CKD, again, if you go about, it is the same GFR reduction, of significant reduction in GFR of that kidney of a cirrhotic patient for more than 3 months. So if you will see that these two conditions can progress to HRS non-AKI, which was previously given the label of HRS type 2. Okay, let's talk of AKI, which is the main topic to be discussed for us as a hepatologist. So AKI has stages. Stage 1 is increase in serum creatinine more than 0.3 milligram per deciliter. Sorry, I have to go by the book, because this is what we have to understand. And an increase in serum creatinine more than 1.5 to twofold from the baseline. It is an interchangeable thing, because one can go, a cirrhotic can go to stage 1 and progress to stage 2, and stage 2 patient can go back to stage 1 with your intervention. We'll talk on that as well. So stage 3 is the severest form of AKI. The pathophysiology is known by us. This is cirrhosis leading to portal hypertension, nitrous oxide release, strengthening vasodilatation, decreased blood flow to the kidney, activating the RAS system, ADH releases, increased sympathetic tone. There is secondary hyperaldosteronism phenomena going on. There is progressive decrease blood flow in these patients. Most of the child C class patients do have this going on all the time in their body. And there is renal failure, which is the functional renal failure. So, what is the progression of AKI? I was seen in stage 1 to 2 or 3. The progression is again defined to a higher stage, stage 1 to 2, or it may need a renal replacement therapy, which is again very hot waters for us to really progress to, because it has lots of mortality associated with that thing. A regression to AKI to a lower stage is a good outcome, which we do see daily with good intervention. Okay, what to do? So for a hepatologist in a pre-renal AKI, we know that there must be a history of oral intake of overzealous diuresis, laxative use, diarrhea, the clinical history, and urine analysis is the bland urinary sediment. There will be patients with ischemic acute tubular necrosis. We have to differentiate this ATN, which will be in somebody who has prolonged prerenal insult, the same previous patient, not treated, presented late. There will be GI bleed, torrential GI bleeds, septic shocks, any infections apart from SBP as well. The clinical history will be there. The granular cast or urinary microscopy will be quite evident. There will be cast, WBC cast, RBC cast. The toxic ATN, again, there will be a history of nephrotoxic medications. This is a rare phenomena. Cirrhotic cardiomyopathy is a rare phenomena. Acute interstitial nephritis. Yes, drugs we give for prophylaxis of SBP can lead to AIN, acute interstitial nephritis. There will be sterile pyuria on urine analysis, and there will be cast, especially WBC cast. Obstructive uropathy, again, in old ages, it can be there. We have to rule it out, but it's a rare phenomenon. Okay, if I see a patient who is undergoing this AKI phenomena, let's talk of our own patient. So, what is the hemodynamic status? Is there an infection going on? There was SBP in our patient. History of diuretics. These patients are inadvertently on diuretics, and that is taken for granted, and we don't take history about that. And the patient tells the next day that I was also taking these medication. I have to continue it or not? So NSAIDs. So lots of GPs, they prescribe NSAIDs in these patients because of their problems with body aches and pains. So do we have something? We had FENA. We are very familiar with this FENA. But there is again one more thing for us to take into consideration, that is fractional excretion of urea as well. Why? I'll talk on it. It's urine sediments. Very, very easy to go about. Okay, if I come to this part of the table, There's FeNA less than 0.5. The fraction excretion of sodium is less than 21%. It's a very validated figure. There are no cost, and there is no response to plasma expansion, which we always do. This is a very good practice from a hepatologist, which is against nephrology philosophy. They stop all fluids, but we give fluid. It favors that if this patient has not improved with plasma expansion, it favors HRS-AKI. And now, if I go with the same, recently, there has been a breakthrough which shows that if the FeNA is not elucidating any of the direction to us, same is with the fraction excretion of urea, there is an intermediate AKI. What to do? Urinary NGAL. So this is available now. And if it is less than 100 microgram, now studies are validating it, then again, in this subset of patients in which we were not helped by this FeNA phenomena, we can go again to diagnose this HRS by this means. What to do for those who have, we have to rule out any active sediments to diagnose ATN. That can be done easily with the help of NGAL and active sediments in the urine. If I go further, is there any hypotension in the course of disease? The patient was in shock for some time. There were any nephrotoxic drugs in the history. So that will give me that where I'm falling, what I'm going to see, what I'm going to... but for us, recently, we have been helped with this IVC diameter. We do it bedside, and if there is more than 2.5 centimeter IVC, less than 50% collapsibility, then we see that it can be ATN. There is no fluid issue. But in the pre-renal, it's very evident that this is less than 2.5 centimeter diameter and more than 50% collapsibility. It's a very easy tool, bedside tool, to say that because the fluid status of a cirrhotic who has edema, who has ascites, is really difficult. And it's a challenging thing. What is the intravascular, effective intravascular volume? You can't say. There's no clinical examination. So IVC on simple Doppler ultrasound is there to see and tell where we are falling. In which category? Urine biomarkers, yes, one can invest in, because you will be helped to rule out the possibility of ATN. Again, just to mention that stage 1 of AKI has stage 1A and stage 1B, two categories, again depending on the serum creatinine. Now what is the thinking background for these patients? We are closely monitoring this patient. We have to remove all the risk factors, nephrotoxic drugs, any diuretic. We have been given fluids to these patients, and now we are watching closely. Either there is a resolution, or there is persistent phenomena of renal failure in this patient, or it is progressing. In the next slide, if somebody is progressing, the creatinine is rising, the output is not 0.5 ml per kg in the initial 6 hours and 12 hours, then again we have to go back and see where we are losing. If there is diuretic still going on, stop it, and it happens. It happens in busy clinical unit. And volume expansion with albumin, we do give albumin, but it is under dosed. Then see the response. Okay, response is there, we have to follow this patient up, but there is no response. Then again, does this AKI meets criteria of HRS? Does it has progress to HRS? Yes, we have to start the vasoconstrictors and albumin simultaneously. And it's not suspected in the clinical scenario, then the treatment for other AKI phenotypes has to be carried out. These are the very clear definitions of response, of intervention, a partial response and full response. The full response is the return of serum creatinine to the value within 0.3 milligram per deciliter. Although in cirrhotics with the existing muscle mass, this creatinine is the overestimation of the GFR, but again, it helps a lot because the autoanalyzers used today, they pinpoint the actual value very predictably. So, if we have progressed to the HRS AKI, previously known as type 1 HRS, what to do? The same what we already do. We have expanded the volume. Now we're starting with the vasoconstrictors. We're giving albumin. We're giving antibiotic to these patients if there are SBPs. And renal replacement therapy for these patients is always continuous veno-venous continuous hemodialysis. They are not good candidates for the traditional hemodialysis. Okay, liver transplantations, simultaneous liver kidney is little controversial, but again, liver transplant has been done successfully in this subset of patients. Probably this is the last slide from the literature review. Ischemic acute tubular injury. This is the lineage: toxic ATN, bile cast, cirrhotic cardiomyopathy, and acute interstitial nephritis. We have to go about this intervention, and we can prevent these patients by not subjecting them to these outcomes. Because these patients are in our follow-up, they don't come one day, they keep on coming repeatedly. We can intervene like this. So our patient had a FeNO of less than 0.5, and they were bland urine, no growth. NGAL was less than 100. Ultrasound shows normal IVC, though there's no collapsibility. Spontaneous bacterial peritonitis and AKI stage 1A was diagnosed. Treatment with antibiotic was given, and her diuretics were stopped. IV fluids and IV albumin was given, and the return of creatinine to the baseline, which was 0.8 milligram per deciliter within 2 days, was achieved, and this was a full response. So this is how hepatologists can intervene. Thank you.
Thank you, Professor Nasirullah, for sharing your insights. Our next and final topic of today's session is role of interventional radiologist in hepatocellular carcinoma. May I please welcome Dr. Najmuddin. He is serving as interventional radiologist with numerous publications and vast majority of experience in treating and managing hepatocellular carcinoma.
Thank you, PSH, for putting me right at the end of the day. Even I am sleepy. So I'm going to talk about my role, in fact, as a intervention radiologist, how I can work with you guys and how I can help treating patients. I have no disclosures, but the management of ACC, as we all do in our clinical practice, is now through an MDT. You can't work alone. It's not going to work any more now for majority of our patients. So we need to have inputs from hepatologists, surgeons, radiologists, oncologists, and now radiation oncologists, plus a pathologist, The role of pathologists is dwindling, but I, for one, believe that they are still the most important people sitting in our case cohorts, which are which have equivocal lesions. So for all of these patients, accurate staging of the disease is required, plus identification of basic tumor variables, which we see in our daily clinical practice day in, day out, as lyrides, definitions, and people describing all kinds of lesions in the liver. But we need to have an insight, in-depth insight into the evaluation of prognostic tumor features. These features are still not built in to the typical lyride definitions in our clinical practices. And then only we'll be able to make a more suitable treatment options or pick up the most correct option for our ACC patients. So it's matching basically every patient with a proper treatment plan for treatment of ACC. So where does an IR person stand? We stand from front to back. In fact, we are the main personnel sitting in the MDT, directing everybody around us, right from screening, surveillance, whether it's upfront screening or surveillance, or while we are treating the patient and we take them back onto surveillance. Diagnosis, staging, assessments of the responses, and wherever it's required to do a percutaneous biopsy. But everybody feels that most important role of an IR radiologist is local regional therapies or treating oligometastases. It's not. It's actually making a proper decision who to treat with what, if a treatment is feasible. So we're still sticking on to BCLC for majority of our decision makings, although it's changed. You can appreciate that the stage B was divided into 3 subgroups. It's not made much of a difference in our daily clinical routine practices because we still rely on the size, the number, the location, and then the performance statuses and CPT, etc., for majority of our decision making in an MDT setting. But what I'm going to hope to do today now is to at least give you an idea as to how an IR person would think in contrast to the rest of the group in MDT, and how we can have an impact in the thinking process of everybody else in that group. So this will not make much of my part of my talk today. We all know that ablative therapeutic approaches are available. Ethanol and acetic acid have been used since, 1960s for treating all these tumors. But most of these new things like thermal ablative parameters have come up, in which microwave RFA and laser treatment with cryoablation, or even HIFO for that matter, is now being utilized to treat hepatocellular carcinoma. We have all heard of ambulotherapy, particularly TACE, DAB-TACE, blah, blah, blah. And all these can be used in combination with or without the thermal or chemical ablative treatments. Radioembolization with yttrium-90 has come up very strong. And as you see on your left, there are a lot of trials which have changed our thinking process in utilizing all these therapies. But most importantly, what is coming back into the game is SRS and CyberKnife. And in fact, the data set, it's still early days for it, but the data set for CyberKnife is just amazing. In my own clinical experience, I feel that it does have a role coming up in our future treatment management plans for a certain size of tumors. So where do we stand with LIRADS? LIRADS just filters lesions for us to take on board as to should we or shouldn't we treat them at all as ACCs. But it does not really have that in-depth insight into this. But at least for our clinical daily practices, it does label it either at 2-1, that is just stay away from this lesion, put it on follow-up at 3, or proceed with whatever intervention is required as far as treatment is concerned. But where does biopsy stand? We all know that there is enough evidence now that non-interventional diagnosis of these lesions is more than adequate. But is that correct? Are we really missing out the game over here? Because what I feel is that this group, which is part of the game or the division, which is LIRAD-M, is being undermined by our daily routine clinical practice. It's not just over here, it's across the globe. If I was to give you a rough idea, up to 30% of the lesions treated in US basically should have been in LIRAD-M. M means anything apart from HCC. So cholangiocarcinomas, metastases, all of these things do mimic a typical LIRAD lesion. But we have to be very, very institute in picking up these lesions. So currently, diagnostic systems and linked management systems, we just kind of lump them up. As you can see, this is a ball. We don't know really what exactly it is. One size fits most of the recommendations and do not incorporate the full wealth of available prognostic data. To achieve appropriate outcomes in patients, we must look beyond the simple diagnosis and recognize the molecular, imaging, and pathologic variabilities that drive the biologic phenotypes. So radiology, pathology, and molecular phenotypes, they have to be taken into account when you're evaluating every lesion. And that's the part which we play as an IR person. So what is in-depth evaluation of prognostic tumor features? So LIRAD doesn't tell us anything about the aggressiveness of HCC. It does not have a clue. So we don't biopsy them. How do we know that this lesion is more aggressive than the one which is going to be discussed next? And there are, we know, variable biologic aggressiveness within a single tumor as well. So there are different grades. And all imaging algorithms do not incorporate prognostic features or subclassifications for that matter. The classification which BCLC 2022 brought in was again based on size and how the patient's status was. So anyways, this is what you all see in majority of the articles which come up. And we know that things change from start developing from regenerative nodules and proceed to early HCC. And then when it's all well set, we label it as a small progressed HCC. So what's happening in the background is most important, and we need to know how to correlate all these parameters with the findings which are available and should be appreciated on the images. So we know that as the tumor progresses and the progression, whatever size it is, the neoangiogenesis starts to increase. And that unless that happens, we cannot label it as a lesion worth even thinking of a tumor. So what is neoangiogenesis? How does it show up on our images? It usually is what we refer to as simply a T-realized lesion. And that means that there is some form of neoangiogenesis developing in the lesion. But that's not enough. What I want you to look at this lesion and see that it's very heterogeneously enhancing. And that's the beauty and the difference of an eye looking at the lesion, that this lesion has more enhancement in this territory and not in this territory. And this tells me about the actual parameters within the context of the tumor itself. I'll come to it as we go along. So the next thing which happens as the lesions evolve is the portal and tracts are taken over by the lesion. In fact, there are more communications from the portal venular and the tumor venular side, less from the actual hepatic venular side. So that's how we look at it on our portal venous phase. So there are shortcuts. So the lesion becomes more low density earlier on after the arterialization. And we all practice that in our daily routines. But most important thing is that if you appreciate the central filling of the lesion is most essential thing. We don't bother about it in daily routine. Venous emptying should also be central, not peripheral. The moment you start seeing a peripheral filling, that's the ring which we see is basically the left out margin or the pseudo capsule kind of a thing. So it has to have a central core which shows neoangiogenesis and loss of portal triad activity. So the next thing is cellular differentiation. That means the normal cells within the liver are unable to develop within this lesion or are not present for that matter. And that's how it shows. The normal liver is kind of black or gray, dark gray. The tumor is totally different. This is a T2 weighted sequence. You can appreciate there is a good interface, and that means the liver tissue is not present within the lesion. Cell density increases, and that's where we come the closest, in fact, to a pathologist when he is looking at the slide on a higher power thing. And you hear this word NC ratio, you hear the word that there is lack of cytoplasm. All these things can be appreciated in every lesion. That's why imaging is taking over pathology or has taken over pathology to some extent. And diffusion weighted images give us that information. So what it tells me that this number of cells per millimeter or micrometer within this lesion has increased to that level where it's actually holding and not allowing the surrounding water molecules to simply permeate through it just the way it normally is doing across the normal parenchyma of the liver. And that's why what we see white over here is essentially the holding up of the water molecular transmission through this lesion. And this is primarily a reflection of high NC ratio inside this lesion. So going on further, intralesional fat. And it's kind of for me, I take it as a pathognomonic thing within the hepatocellular carcinoma, the presence of fat. It is easily assessed with MR, and even on CT for that matter. So if you look at this same lesion on a simple T1 weighted sequence, this is how it looks like. You can see the lesion, but you don't know the internal architecture. And once you do a chemical shift imaging that is displacing the fat out, you can see that the normal liver also is fatty, but the tumor loses most of the fat inside it. So this blackness within the lesion is reflective of presence of fat. So even if I biopsy it, I might not get the entire specimen out, and the pathologist would say that there is no fat in it. But I can tell you that there is. And I can go back and argue with the pathologist that you look at a deeper level, there must be some fat in it. And then moving on. So all the parenchyma, normal parenchyma, has a lot of iron in it. So lesion, as it grows, the iron simply goes out. And that was what I referred to earlier on. But then moving on, the ionic movement of contrast, the anion thing of TP1B and B3 expression reduces. And this is where the new agent, which is beta-catenin, is coming into action, because that upregulates the expression of this gene. And I'll show you how it works. This is a hepatobiliary contrast medium used, the specific hepatic contrast medium used, and it will be taken up if this parameter is present. If there is no uptake on the cellular level, you will have a very discrete low finding. So I can tell you up to this molecular level what I can see within a lesion, and that is what is most important. Let's move on. There is a huge long list of things which will reflect on the prognostic imagings of the lesion. I won't go into this list, but I'll show you. I need to know, and we in MDT need to know, how are the margins? Are they clear, discrete, or not? If they're not, then obviously this is an aggressive lesion permeating into the normal surrounding parenchyma. On a peritumoral hypointensity seen on a hepatobiliary contrast medium, I can tell you that the surrounding area is good or there is infiltration into it. Similarly, if you look at this, the peritumoral enhancement will tell me whether the microvascular architecture or the microvenular architecture around the tumor. How is it behaving? Is it infiltrated? Has the tumor gone into it or not? And if you see these large multifocality type of surrounding nodules, that's fine. We know that the lesion is not what we are actually measuring. The lesion is bigger than what we are measuring. And that will have an impact on our management. So I'll skip this one. I'll skip this one as well because I'm over the time. And what this slide was supposed to show was that the recommendations are quite so comparable as far as treatment plans are concerned for lesions of different size with different characteristics between BCLC, Chinese, and NCCN guidelines, and even AASLD. But let's look at these few images and then I'll let you go. This is a lesion at the periphery in segment 6, partially exophytic. You can, as I've already highlighted, tell that it's not the same level of enhancement within it. The perfusion or the venous emptying, I can argue again, it's difficult to tell, but on the delayed scan, the venous emptying is more or less homogeneous. On the coronal feature, this tumor has a very sharp edge over here. I can't tell you what is happening over here, but this is the true hub or the center with maximum angiogenesis within the lesion. So that has to be taken care of. And this is partly exophytic. But it's a small tumor, so it's something like 22 millimeters. So what would you take for best modality to handle this lesion? Because it's a small lesion, it's a periphery, and I, for one, with the help of my MDT, can make a decision that I can cover at least 1 centimeter of the normal surrounding parenchyma, and I feel that disease is not beyond it, then I'll simply do a microwave, and that's what I've done in a lateral position, taken more than what I actually should have, and on follow-up you can appreciate how much of the area has been taken up by a microwave. And it does not now matter really. So you can be concerned whether it has gone beyond the capsule towards the kidney. There is an effect on the kidney, but the larger area is just a surgical approach. They would want to take out at least 1 centimeter of the surrounding normal parenchyma, and that's what we take out while we're doing MR. Here is another example going through this quickly. It's a larger lesion, very complex area right at the top, segment 5, under the diaphragm. I can make out, and I'm sure you all can also make out, that the outline of the lesion is pretty smooth over here. And I can tell you that, tumor finishes here, tumor starts here. And when you look at the lower end of it, you can't make out this outline. And that's the trick of the tumor. When it's drawing vascularity, like in this case, drawing vascularity from the phrenic artery, it will not have that outline, discrete capsule, which we are used to seeing. Sorry, just finishing. Moving on, we made a decision here that this will not work. Only simple microwave will not work in this patient. So we decided that this patient will have to be bombarded with the maximum things. So I did and this is a recent case, I did a test on this patient, and as you can appreciate, there's not much vascularity from the liver side. What this reflected to me was the majority of the vascularity was being drawn from the phrenic aspect, right phrenic artery, not from the right hepatic artery. Anyway, we did it, shut it off from here, did a microwave the same day, and this is a larger lesion, as you can appreciate. This is up to 57 millimeters, and we compounded it. This is a follow-up after 3 months. You can appreciate that the lesion is gone, and another 3 months, this is a lesion which is well encapsulated. We have a lot of fluid around it. This is because of the complications which we had from the gallbladder empyema. But what has happened is that we've had a small shunt develop around the lesion. But that's fine. Another lesion, if you don't see the margins nicely as I was highlighting, no choice. And the parameters are written down there. This is a patient with 70K. And when we did a taste on this patient, because we thought it was big, we could see satellite nodules. So once we have taken care of the satellite nodules, the peripheral intervention, we microwave this as well. And that's the beauty of looking deep into the, having insight into the characteristics of a lesion when you are making such a decisions in an MDT setting. So again, repeating the same thing, look deep into the lesion in an MDT, and then only you can make a good decision for your patients wherever you are practicing. Thank you very much for your patience.
Thank you, Dr. Najmuddin, for a wonderful talk. In the end, I would like to thank all the speakers for their engaging and informative presentations, and our chairpersons for their guidance throughout the session. We had a productive and insightful discussion on several clinical topics. I would like to express my gratitude to all of you for your active participation. And in the end, as we conclude, I encourage you all to take the knowledge shared today. And final words from my chairpersons, if they have any. So I would hand over the mic to them.
Thank you, Ms. This was a wonderful session. Addressing the most commonly encountered in practice topics. As far as concerned, the bleeding in the CLD. Though these were the endoscopic procedures, but it becomes very challenging when we encounter the major surgeries. Just we receive call from the surgery and that they are going for the lap chole, and sometimes they open the case. So how they manage? So these were the really very challenging conditions. And second, Gibran said the drug-induced liver injury. As the name said, it is the drug-induced. It may be missed if we have not a good history. Rather than you say that it is the diagnosis of the exclusion. Whenever there is no good history, we will miss the diagnosis and we will go on the pathway of the to work up of a diagnosis of the exclusion. While Dr. Nasr Lak, very common topic, very good expression and good cases were shown. And in the last, in the radiology, the new system of the LIRAD to make a diagnosis of the malignant and non-malignancy. This was a very good topic. Thank you.
Thank you very much. Very informative and practical talks. We, as a gastroenterologist, see colorful images, and Dr. Najam made it very simple. And thank you for teaching us how to look at the liver lesions in a simple term. Dr. Jabran talks was excellent. I think the learning point is, key point is the history, emphasized very nicely. We recently had a case of drug-induced liver injury. We exhausted all the resources, and the clue which gave us was a history. The patient was taking turmeric or haldi tablets, and that can cause a liver injury as well. And that came at the very end of the pathway. So basics are important. Very nice talk by Professor Sher Rahman. Don't worry about INR. Platelets numbers are important, so don't waste resources in checking INR for basic clinical scenarios like paracentesis or basic procedures. It's not only cost effective, but also it can be dangerous over transfusing blood products to the patients, viral transmission, etc. And my last point about the AKI is a very difficult topic, but the low role of vasopressors such as telepressin, be mindful if their creatinine is very high. There's been recent studies, values of 430 and above. Telepressin actually can produce lung injury as well and can be harmful. So in worsening AKI, maybe you want to avoid telepressin. And thank you very much. Enjoyed the talks.
in the interest of time, I thank the PSH for inviting all of us and all the presenters for their excellent talk, and especially the audience for patience listening. Thank you.
Thank you all attendees for making this session a success. Thank you all. Enjoy the rest of the conference. Jazakallah.
Assalamu alaikum. I'm Dr. Najmus Saeed. I'm from Gujranwala Medical College, and I'm your moderator for the last session with a lot of pressure of time because we are short of time. So straight away we'll start the last but not the least most important session about the reproductive health and liver disease. To invite the chairs on stage, first I would like to call upon the Professor of Internal Medicine, Head of Department Medical Ward, Professor Dr. Israrul Haq Tur Saab, a very vibrant and energetic, kind senior. Sir, kindly take your chair. We have another, our very kind and very energetic senior consultant, gastroenterologist, hepatologist, Professor Dr. Aftab Haider Alvi Saab from Fatma Memorial Hospital. Kindly join us, sir. To complete the chairs, we have a young consultant, Assistant Professor of Gastroenterology, Hepatology in Services Institute of Medical Sciences, Dr. Junaid Mushtaq. किसी ने मुझे कहा कि सबसे अच्छे शायर जो है ना वो मुशायरे में सबसे आखिर में आते हैं, तो हमने भी आपके लिए सबसे अच्छे स्पीकर सबसे आखिर में रखे हैं. तो I would like to call upon now our speaker. He was the meritorious professor and dean in Dow Health University, and he was the head of the clinical trial unit, has more than 100 publications to his name, a very vibrant personality in Pakistan Society of Hepatology, Professor Dr. Badr Fayaz Zubairi Saab, and he would tell us about the approach, how to approach a patient with pruritus in pregnancy. Professor Saab.
Assalamu alaikum. So, my topic today is pruritus in pregnancy and what's its diagnosis and how to approach. Well, I have no disclosures, and a new pruritic lesion that occurs during pregnancy requires immediate evaluation and diagnosis, because a delay in diagnosis will result in disastrous or sometimes problematic use of pregnancy outcome and to the fetus. We need to know the physiological changes that occur during the pregnancy. That pregnancy is associated with complex endocrinological and immunological, metabolic and vascular changes that may influence every organ in the body, which includes skin also. Almost all pregnant patients notice increased pigmentation, hyperpigmentation, increased pigmentation around areola, linea nigra, and changes in neva, etc. Stria gravitum, also known to stretch marks, and occurs in many pregnancies as a result of skin stretching combined with genetic and hormonal factors, and may be the cause of itch in pregnancy. In addition, eccrine sweat gland and sebaceous gland activity increases and apocrine gland activity decreases in pregnancy, which may also contribute to pruritus in this group of patients. Knowledge and the ability to distinguish between physiological changes and the skin in the pregnancy is necessary for a proper differential diagnosis from pathological symptoms and to avoid unnecessary treatment and investigations. So we have divided the pregnancy-specific pruritic disease into the 4 areas, which are the ectopic eruption of pregnancies, polymorphic eruption of pregnancies, pemphigoid gestationitis, and intrahepatic cholestasis of pregnancy. And if you look at the timeline of these patients, of these events, different, you see the ectopic pregnancy, eruptions of pregnancy starts from the first trimester and usually ends within the second trimester. And we see the intrahepatic cholestasis of pregnancy starts from the second trimester and goes to the end of the third trimester and disappears after delivery. While the pemphigoid gestationitis may start from second and may go well beyond the delivery. And polymorphic eruption also starts in the third and may go well beyond after delivery. So what is ectopic eruption of pregnancy? It is in 2005, Ambrose Rodolphe et al. Introduced the term AEP as an umbrella concept for a benign pruritic disorders of pregnancy, and it covers all the patients formerly diagnosed with eczema of pregnancy, prurigo pregnancy, pruritic folliculitis of pregnancy, and is the most common dermatosis that is seen during pregnancy. This term covers both patients and exacerbation of pre-existing ectopic dermatitis and patients experiencing skin manifestation for the first time during the pregnancy. Patients with a family history of atopic dermatitis are at risk of developing this disorder, but the disease is frequently idiopathic. If you look at the pictures, images of the AEPs, these are the images that can show them. Pathophysiologically, the pathogenesis of ectopic exacerbation of pregnancy is not fully understood. As in ectopic dermatitis, it is mainly considered to be a T helper type 2 driven disease. In pregnancy, there is a shift physiologically from Th1 to Th2 mediated immunity occurs, and which may lead to exacerbation of ectopic dermatitis during the pregnancy and the manifestation subsequently of AEP. It usually starts earlier than other pregnancy-specific dermatosis, potentially even at the start of the pregnancy, and recently studies have shown that the patient without ectopic background are more likely to experience onset of the disease in the second and third trimester. The diagnostic workup for this is patients are usually present in early onset, and histologically it is there's no specific disorders are seen, so the biopsy of the skin is not helpful. Direct immunofluorescence and indirect immunofluorescence results are often negative, and laboratory test results indicate elevated serum IgE levels in about 30 to 70% of the patient. It is not clear whether IG level should be considered as a diagnostic criteria, as it's not been studied specifically until now. The treatment has a pyramid, and it starts with topical emollients, with topical steroids, going up to narrowband UV phototherapy, and then to systemic steroids and immunosuppression in very resistant cases. Prognosis, this patient should be reassured of excellent prognosis, as AAP is not associated with adverse fetal outcomes. However, depending on parents' ectopic background, the child might be predisposed to ectopic eczema, and disease might occur in subsequent pregnancies also. Then the polymorphic eruptions of pregnancy is the second topic, and it is known for pruritic urticarial papules and plaques of pregnancy, and is benign self-limiting pruritic inflammatory disorders. It occurs in the third trimester, and the risk factors include first pregnancy, prima gravida, excessive maternal weight gain, and multiple pregnancy. These are the images from this disorder, and pathologically it is a stretching of the skin on abdomen at the third trimester of pregnancy or over multiple pregnancy that may activate dermal nerve endings, leading to pruritus. However, the exact pathogenesis of PEPs remain elusive. Another theory suggests that damage to collagen fibers may induce an allergic type of response contributing to development of these lesions. The clinical presentation include polymorphic lesions, which are highly pruritic urticarial papules that co-seal to form plaques of 2 millimeter in size, but there is no bully, and widespread non-urticarial erythema and targoid and eczematous lesion, generally sparing the periumbilical region. It usually starts in the abdominal region with striae, distensi, and if they are present, the disease spreads to other parts of the body, such as thighs, buttocks, and the rest of the trunk, and but the involvement of distal limbs and extremities is very rare. There are no characteristic histological or immunofluorescence findings also in this disorder, and diagnosis is purely based on clinical presentation, and the disease resolves spontaneously within 4 to 6 weeks of the treatment and is symptomatic. And the treatment is the same pyramid as I shown in the previous disorder. The disorder is self-limiting and does not affect prognosis for the fetus or pregnant patient. Recurrence is rare, as it usually occurs only in the first pregnancies. So subsequent pregnancies, it usually doesn't occur. The pemphigoid distensions, gestation, also known as herpes gestationalitis, is a rare self-limiting pregnancy-associated bullous autoimmune disease. Although it occurs in the late trimester, it may develop at any time during pregnancy or in immediately postpartum period also. The incidence is approximately 1 to 2,000, 1 to 60,000 pregnancies, and it depends upon the prevalence of human leukocyte antigen, HLA haplotype DR3 and DR4. Relapse of the disease is common in further pregnancies and often occurring at an earlier stage and in a more severe form in the subsequent pregnancies. And you can see the bullous eruptions in these diseases occurring during the pregnancy. The primary site of autoimmunity in this disorder is placenta rather than the skin. The proteins presented in the placenta are recognized as foreign, which leads to production of antiplacental IgG antibodies, which cross-react with BP1802 proteins on the skin. Binding on these antibodies to BP180 and BP230 is the hemidesmosomes of the dermatoepithelial junction that triggers an autoimmune response, which is followed by complement activation and disruption of basement membrane. Patient usually presents with severe pruritus and subsequent polymorphic inflammatory skin lesion. At first, the erythematous urticarial papules and plaques develop on the abdomen, characteristically involving the periumbilical region, with later spreads to other part of the abdomen and extremities. Later on, the lesions may progress to intense blisters similar to those in bullous pemphigoid. Direct immunofluorescence or peri-lesion skin lesion together with clinical finding remains the gold standard for establishing the diagnosis. The immunofluorescence shows linear C3 or IgG deposit along the dermoepithelial junction, and detection of circulating and autoantibodies by ELISA usually seen in these patients with hypersensitivity reactions. The natural course of this disorder includes remissions and exacerbations during the pregnancy, with characteristic flares occurring during delivery or immediate postpartum period and resolving spontaneously within 4 weeks. The disease may also flare after abortion, and the treatment of this disorder mainly focuses on reducing pruritus and preventing formation of new blisters. The treatment of choice is high-potency topical corticosteroids and antihistamines are required for this treatment. Short courses of prednisolone can be introduced, which if remains refracted, the treatment is upgraded to steroid, systemic steroid, and intravenous immunoglobulin, dapsone, azathioprine, and could be instilled in this patient. Intravenous immunoglobulins have a good safety profile for the patient and fetus and should be used either in monotherapy or as adjuvant therapy in this patient. Dapsone is also considered safe during gestation in this, and vitamin E and vitamin C supplements shown to have decreased the risk factors in this patient's group of patients. The risks include preterm labor and intrauterine growth retardation and are most likely probably linked to the severity of the disease itself rather than the treatment. This is associated with the increased risk of other autoimmune disorders as in pregnant patients, especially Graves' disease, which may be explained by the presence of HLA-DR3 and DR4 haplotypes. The disease tends to reoccur in subsequent pregnancies. The fourth and the last is the intrahepatic cholestasis of pregnancy. ICP is a liver disorder unique to pregnancy and has been reported in the incidence of 0.3 to 5.6%. The mutation of ABCB4 involved in the biliary secretion of phospholipids have been studied in ICP and may play an important role in at least some of the patients. The disease associated with ICP include gallstones, hepatitis C, preeclampsia, and gestational diabetes, etc. This is characterized by an inability to excrete bile salts from the liver, which increases serum bile acid concentrations, causing pruritus and negatively influences the fetal prognosis. It is a reversible cholestasis that occurs in the second or third trimester of pregnancy. These are the images. Potential etiological factors include genetic expression of hepatobiliary transport proteins, hormonal, environmental factors such as seasonal variability in the diet. Recent studies have explored the role of alteration in the gut microbiota along with the therapy with vaginal progesterone preparation as a potential risk factor for this disorder. The clinical triad characteristics for this disease include severe pruritus, jaundice starting at 2 to 4 weeks after the onset of pruritus. So pruritus precedes the onset of jaundice and elevated bile salts. The disease is characterized by elevated bile acids in maternal blood more than 10 micromole per liter, and abnormal liver function tests, mainly serum transaminase, are elevated. Although the disease is historically linked to jaundice, more recent data have indicated that yellowish or greenish pigmentation of skin and whites of the eyes is reported only in 10% of the patient. Pruritus classically begins on the palms and the sole but may become generalized. Patient present without skin alteration apart from secondary scratch lesions. Diagnostic workup should include and focus on exclusion of other clinical entities, including the differential diagnosis of cholestasis and hepatic diseases, and on increased serum bile acid levels of more than 10 micromole per liter. Mild increases in liver transaminase level include aspartate aminotraces and alanine aminotransferase are also excluded. Ultrasound examination of abdomen and serological tests may be helpful to exclude other causes of underlying disorders, and diagnosis is based on characteristic symptoms of pruritus starting at the palm and sole without primary lesion of the skin, together with increased total serum bile acid levels. This usually resolves spontaneously within 6 weeks after delivery. The primary goal in the management of ICP is to reduce serum bile acid level, which is proven to reduce pruritus along with pregnancy and decrease fetal risk. The first line treatment is administered of ursodeoxycholic acid at 15 milligram per kilogram per day in divided doses. The role of synergistic effect of rifampicin at 300 to 1200 milligram on bile acid clearance in severe ICP is still being discussed and should be considered when there is no improvement with UDCA alone. Early term induction should be discussed with the patient, especially after gestation of 37 weeks, and if the bile acid concentration are more than 100 millimoles per liter. Prognosis: the ICP has been associated with increased rates of fetal complications, perinatal mortality rates, stillbirths, low birth weight, preterm birth, and fetal distress during the pregnancy. Now, these are the tabulated form of the feature of the 4 disorders. I'll rush through because of the constraint of the time, and then thank you very much for your patient listening.
This brings us to the last talk for last session of PSH 2024. And for that, I would like to invite on stage our consultant gastroenterologist, hepatologist, all the way from NHS, and he's been trained in Nottingham University and from USA and Germany, Dr. Saqib Ahmed. And he's going to talk about HPV in pregnancy.
Thank you very much for a kind introduction. And you guys are real enthusiasts and heroes staying till late to listen to this talk. I can just go to the learning points and finish it off, but I think we'll just skip through some interesting slides. And thank you for PSH for inviting me here today, which is a pleasure. So we're going to discuss not only pregnancy, but pregnancy phase, what happens with mother-to-child transmission, which is the most important bit, because you are dealing with two lives. And don't forget the baby when it's born, because it's important. The care doesn't finish with the birth. It carries on till the baby is 1 year old at least. It's a global problem. The numbers are increasing. This slide is from WHO a few years ago. And 65 million of these, about 257 million people are women of childbearing age. And it is the most important cause of global transmission of chronic hepatitis B cases of almost about 50%. And it's the most important key step we can address to reduce the transmission. So the planning starts with pre-pregnancy phase. Fortunately in Pakistan, females population is growing, as well as a major bulk is in a childhood bearing age, so we should screen them. And if they are found positive, then there's lots of issues to discuss. Would you discuss with them treatment? Would they need contraception? Would they need low-level viral loads before they get pregnant? And I think any opportunity we should get, like hospital visit, we should screen them for hepatitis B, because that's important for their future as well. And what is the treatment in a woman of childbearing age? I think we have to risk stratify them with a simple fibroscan can help. If their values are F3 and above, they might have advanced fibrosis. And I think that's where still the role of dreaded PEG interferons are there before pregnancy, because it's a finite treatment, 48 weeks. You can achieve surface antigen loss in about less than 10% of cases, but it is still there. Or you can, if they have low fibrosis score, you can defer treatment and they can plan pregnancy. If they have advanced liver disease, treat before pregnancy, during pregnancy, and continue treatment after delivery. And the spectrum of liver diseases changes if they have, I think it doesn't work. If they have low fibrosis, no risk of decompensation, then you can treat pregnancy before you treat Hep B, and you can carry on forward after their delivery. What happens with pregnancy and hepatitis B? We have discussed whole day the causes of hepatitis in pregnancy. And if you have a very high ALT, one of the differentials you must consider is hepatitis B, along with hepatitis E, which is common. Hepatitis B, fortunately, during pregnancy, which is acute, is usually mild and is not associated with increased mortality or tetragenicity, so you can reassure the ladies. However, there might be slight increase in low birth weights and prematurity in certain studies which has shown. The worrying bit is if the viral load is very high near the delivery, which is the third trimester, then the risk of transmission, fetal transmission, is about 10 to 60%, and that's where we need to monitor them. Mainly treatment is supportive. It's not necessary to give them antiviral therapy, but only if they develop acute liver failure or they have severe hepatitis with very high viral loads and you're worried about fetal to maternal transmission, then you can consider tenofovir, which is safe during this time period. Chronic hepatitis B, what is the effects of pregnancy on the natural history of hepatitis B? Again, fortunately, the risk of flares are minimal. Most of the flares are mild and they settle down without any effective treatments, but the risk is there. Most liver disease itself doesn't get worse during pregnancy. However, if it's advanced liver cirrhosis, then the fertility also goes down, so risk of getting pregnancy is low anyway. Fortunately, the hepatitis B DNA levels remain stable during the pregnancy, so we can reassure mom that chronic hepatitis B, if well monitored in pregnancy, is not detrimental to the fetus. Hepatitis B on pregnancy, what it does, sometimes there are some studies which suggest increase in incidence of gestational diabetes mellitus, babies with low Apgar score, so they need monitoring, some incidences of preterm delivery as well. And generally there's no association with adverse pregnancy outcomes, so reassurance comes a long way to the pregnant lady. If they are pregnant and they're already on a treatment for hepatitis B, if they are pregnant on PEG treatment, you need to stop it. If they are on nucleoside analogs, consider discontinuation carefully, because they might get severity the severe flare-ups, or they might have advanced liver disease. These are all the risk factors you have to consider. And if they are on nucleoside inhibitors, replace FDA class B with class C with class B, which is tenofovir, which is safe in pregnancy. If they get pregnant and they are not on treatment, then you have to consider the risk-benefit ratios of the pregnancy, treatment cost, and whether you want to treat hepatitis B itself or you want to reduce maternal to fetal transmission. Just to remind all antivirals we have now is only tenofovir, which is class B along with telbivudine, but telbivudine has a high resistance rate, so it's not preferred medication. So if you have to only use tenofovir. Even the new variant, which TAF, is not licensed in pregnancy yet. And the tenofovir, most of the data comes from HIV cohorts from America, from the registry, or expanded over 2 decades. And the people who have been on tenofovir, the incidence of birth defects is only 2.4%, whereas in general population, the incidence of birth defects was similar, about 2.7%. So they are pretty safe medications to use in pregnancy. And the indications for antiviral in pregnancy in pregnant women are generally the same as those of the patients which are not pregnant, that is without cirrhosis and with cirrhosis, hepatitis E antigen positive or negative. We follow the EASL guidelines. If they are E antigen positive with more than 20,000 international units, then you treat them. If they are negative, then 2,000 is the cutoff. However, if they have no advanced liver disease, but their viral loads are very high, then you should initiate treatment in the third trimester, and the goal is to prevent maternal to child transmission. It's an interesting fact to note is the hepatitis B virus, because of the sheer size of the virus, it doesn't cross placenta, so it doesn't directly infect fetus. The main transmission occurs in perinatal phase, about 60 to 80% of the cases, and that's mainly because if there is a injury or microtransfusions during the birth or the swallowed blood. So that's the most important phase you need to concentrate. Sometimes there's postpartum transmission as well, and 10 to 13% in intrauterine infection, etc. also risk in microtransfusions, microabortions, which can result in hepatitis B transmission. So what is the risk of mother to child HPV transmission without prophylaxis if they haven't received tenofovir, but if they are E antigen positive and E antibody negative, the risk of transmission is 90%. You can simply risk stratify them. If they both are negative, it means they haven't developed antibodies, then the risk is about 25%. However, if they have anti-BE antibodies positive, but E antigen is negative, the risk is reduced to 12%. So you can risk stratify your patients. This is important because then you need to vaccinate or post-exposure prophylaxis of the babies. It's very important to give them immunoglobulins as well as hepatitis B vaccine at birth within 12 hours, or ideally within 24 hours to prevent transmission. But that doesn't work in 100% of the cases. If you give both, it's effective in about 90 to 95% of cases. Immunoglobulin alone is 70%, and vaccine alone is also 70%. Despite this, maternal to fetal transmission can occur, and that's why it's important to target the last trimester with antivirals. And this eloquent study very rightly showed two risk factors. If they are E antigen positive, and if their viral load is more than 5 into 10 raised to 9 log, which is equal to 2,100 international units, or 2 lakh units is other viral load hai, then you should treat them with antiviral in third trimester, despite because the evidence is that they will develop fetal to maternal transmission, which is linked with a high level of maternal hepatitis B DNA levels. And the use of antiviral have been shown effective by these 2 studies from Australia and Taiwan, in which they have an untreated group which have a transmission rate of 20% and 10% in Taiwan. But if they have tenofovir prophylaxis along then the risk is remarkably reduced to 2% or less. And those both groups received hepatitis B and immunoglobulins at birth. So it is an important consideration which has been well summarized by the guidelines all over the world. There's not much difference in all these guidelines. They all recommend using tenofovir as a first-line agent with viral loads more than 200K international unit per mil. There's a little bit difference in the starting time period of these guidelines. And I think in Asian populations, what the experience is, the hepatitis E antigen positivity, as you know, is associated with a very high viral loads. And in Asian women, they are in millions. So if you're going to start nucleoside inhibitors, they reduce viral load by 1 log per month. So if you start late in pregnancy, by the time you hit the low levels, less than safe levels, it might take them to 50 weeks. So, and the pregnancy might not last 40 weeks. So start early. These medicines are safe. I would recommend consider starting as early as 26 weeks of pregnancy. When to stop, that could be contentious, but if you have given them maternal to child prophylaxis, then at least continue antiviral till 3 months after birth, as the flare-ups of hepatitis B in postpartum phase are there. There's a risk of 10 to 15%. I'm going to skip this slide in interest of time. But don't forget, once the newborn is born, that is still the part of management, and it's more important because there's no cure for hepatitis B, and the earlier in phase of life you get infected, the most chances are you're going to get a chronic hepatitis B infection. So if you're infected at the neonates, the risk of growing as an adult with chronic hepatitis B is 90%, whereas if you get infected with hepatitis B as an adult, the risk of chronic infection is 5%. And that is why we need to worry about the prophylaxis, reducing maternal to child transmission, as well as continue to look after the baby once it's born. And this is the slide I want you to concentrate. So at birth, a baby born to a hepatitis B positive mother with high viral load, please making sure they get both immunoglobulins as well as hepatitis B vaccination within 24 hours. Don't forget they need the second and the third dose at age 1 month and 6 months. And then they review. The most important point is they need a review at 9 to 12 months after birth, and you need to check their 2 things, hepatitis B surface antigen and anti-hepatitis B surface antibodies, to risk stratify. If they are negative for surface antigen and positive for anti-BS, that means they are vaccinated, responded, and seroprotected, and they can have a future. However, if they are both negative, it means they are vaccine non-responders, and you need to give another dose of vaccine. If they are surface antigen positive but anti-FBS negative, it means they have hepatitis B infection, and you need to refer them to the pediatricians to continue look after. Currently, there's no medication which are licensed to treat infants, and all the licenses of hepatitis B vaccination starts at the age of 2. So hepatitis B in pregnancy is important. You not only have to look after the mother, but you have to treat the fetus and the both. And I've summarized the take-home points. Should antiviral therapy be recommended to reduce the perinatal transmission? Yes, this is effective. It reduces the transmission rate to less than 1%. Should the cutoff of maternal HPD, there should be a cutoff of viral DNA for initiation of antiviral therapy. We have shown that higher DNA levels with a cutoff of 200,000 international unit per mil is associated with a steep uprising curve in transmission. So that is the level you need to target. When to start? The sooner the better, late second or early third trimester. Don't delay more than 26 weeks. As I've shown you, it takes a time for those levels to come down. Which antiviral drug, tenofovir, is safe and is the only effective one which we have at the moment. When to stop? At 3 months, you can risk stratify and stop, or you can continue treating depending upon the liver disease stage of the pregnant woman. What is the risk of post-treatment flares? Monitor if you think to stop therapy, then you have to monitor the ALTs at 1, 3, and 6 months. And then most important question, hepatitis B is secreted in breast milk. There's a risk of transmission, but it is safe, and all the societies do recommend breastfeeding. The risk weighs out benefits of breastfeeding. And I think you have to advise if there's nipple crackling or there's a visible blood, then they should, the ladies should take care of that and avoid feeding babies in that bed. But otherwise, it's generally safe and is allowed. I think with this, I'll finish my talk. And thank you very much for persuading and listening.
Thank you very much, Dr. Saqib, to keep it simple and up to mark at this sleepy hour. Now, for the conclusion, I would like the chairs to kindly have a quick and short comments.
Always very good in difficult topics like dermatological manifestations during pregnancy is a difficult topic to understand, but he's very excellently covered very important aspects of all the clinical aspects of this clinical condition. Dr. Saqib, he has given a very practical aspect, very practical points regarding the management of hepatitis B during pregnancy, and both the talks were very elegant. And thank you very much for the nice talks.
These are very practical topic basically, and on the day-to-day basis we come across with these cases, and very comprehensive talk from both of the speakers, from Dr. Saqib and Dr. Zubairi, especially Dr. Zubairi. They teach us dermatology as well, and now we can differentiate between ICP and other dermatological condition. So very nice talk. Thank you very much.
Hepatitis B itself is very complex to understand, and I believe that pregnancy and hepatitis B is like walking a walk and talking a talk kind of a situation. And both the presenter made us acquainted to the better understanding of the topic. Thank you very much.
This brings us to the end of our session. Thank you very much for your patient listening. Okay, now I'd like to invite the chairs and the speakers for the group photo. Yeah, okay.
Assalamu alaikum. After the picture, we have a general body meeting in which all associate, regular and lifetime members are invited to express their feelings and give suggestions to the society in the side hall, which is exhibition area. Thank you.
Vale, vale. हाँ दवाई हेलो हेलो हेलो
you.